Sir, we have to wait another 10 minutes. 7 minutes. 8:30 we are starting. I think it's 8:30 only. I made it 8:50 so that people come and sit. Let's sit over there.
हो गया. बढ़िया.
Anubha madam and Cecilia madam had gone at 6 o'clock. Then again, 3 people were waiting for the taxi. Manjuna lady said was fully gone crazy only. How many taxi now? Now Karthik sir also one taxi is going to pick him up. 8:15 is time.
ये सारा पैसा भी करो इकट्ठा करो क्या करते फिर पैसे लेके want to look at it. मुझे सुबह बात की हमने so much early morning. Plan yourself. You are a senior person, ma'am. You know how I'm working. 100 rupees calculate and plan. You should hold responsibility, sir. This transportation not if you put on our head, should we operate? Should we focus on patients? Should we focus on conference? This is too much. People henceforth are not disturbing. You plan yourself. In spite of all planning, still you are unable to. No, they will tell you this. So another reference. What is it? Don't worry. We'll take care. You are the chairperson. Please be seated. And if you allow, I will come as chairperson. Speak with you. You cannot. Because to take permission, because my name is not there in the list. Thank you. कितने बजे निकले सुबह?
I reached at 7.
ठीक है क्या कुछ काम करना पड़ा होता है? They've done everything.
Oh sir.
कल पीछे का बोर्ड टेढ़ा था स्टार्टिंग तो किया ना डाटा उनको चलो कल हम बोर्ड लगाए ना let's see now they are working on that everything to be perfect you have to give ये और एक चीज है मुझे कल जगन्नाथ मधुमती में on duty thought I will hang on today
yes sir
more is it to cover Tuesday can take off ऐसा कुछ करेगी प्लान करेगी ये जोकर से है उसके लिए on conscious because it's our responsibility अगर टाफ ठीक रहेगा तो सब बच्चों लोग को हम नीचे ले लेते हैं उनका झंझट ही नीचे कल वो बंदा इग्नोर कर रहा है तो विदाउट टेलिंग मी ही हैज पुट इन वन ऑफ द ग्रुप्स एंड ऑल दैट ही वांट्स एन असिस्टेंट उसका नाम लिख के भेजा है वो एंड वो डॉक्टर से बात किया अविनाश क्या नाम उसका ये बात कर अम्मा आज जाने का टाइम बात कर
it's finalized.
They are planning for an interview and this fellow I think he's already primed him to work under her and I don't know how competent he is. If he's not competent he'll agree to work under her. That's the problem.
He's like not very senior.
Can we discuss something instead of chatting?
Okay.
First day you record bleeding. First day. Patient has come from the OT. Why you record bleeding? Now, why you want to record bleeding? First hour, I told you, make it 0 and start counting. And first hour is say 90, next is 80, 70. Why are you recording this bleeding? Sorry? Oru maamida pesha pora. Very good. So that is called replacement of hemoglobin. Correct? Any other reason? Simple. And take the patient again to operation theatre for re-exploration. Correct? So remember, the first day, it is more important to report bleeding every hour to decide one, replacement of hemoglobin, that is blood. Number 2, more important, re-exploration. Second day, why you record drainage? Normally, no. Normally, within 6 hours, patient should be this way or that way. Okay? Second day, why you keep measuring? Amma, active bleeding ayache. This is second day, pudusa, to remove the drain. We want to know whether we can. First question patient asks is what? When you can remove this, when you can remove this, when you can remove this, when you can remove this. Correct? Patient is constantly interested in that. So second day, you need not measure every hour. Second day onwards, it is removal of drain. Very good. Patient draining 80 ml, 70 ml. I am phoning you. Apart from bleeding, what will you report to me? Color of the drain. Very good. Thick or thin. Anything else? Ayu amma ayache. Color of the drain. Never forget to correlate with hemoglobin. And number 2, CVP. Yesterday the doctor was telling you, blood can collect inside, clot inside. Drain 0. But blood can clot inside. So always bleeding should be correlated with hemoglobin. Remember your lifetime. Still time, na? You tell me when to stop.
Yes.
What happens to hemoglobin? Patient has come from the OT at 8:30. What will happen to hemoglobin? First blood gas, hemoglobin 7.8. What will happen to this patient's hemoglobin at 9 o'clock, 10 o'clock, 11 o'clock? It will drop because of bleeding. Will it go up? Anybody? It will go up because patient on bypass is hemodiluted. First 4 hours, patient passes how much of urine? 300, 400 cc urine. So if water goes out, what will happen to hemoglobin? Don't say hemo concentration. Hemoglobin will go up. So if patient comes to you and hemoglobin next blood gas reading after 2 hours shows hemoglobin up, you are happy. Okay? I think we'll stop and start.
Good morning and Sairam, esteemed faculty and dear delegates. I welcome you all to the second day of the first International Nursing Conference on Pediatric Cardiac Intensive Care. I hope all our nurses slept well, are rested well, and dreamt only about the anatomy, physiology, hemodynamic monitoring, low cardiac output. Yes. So let's continue this academic extravaganza by calling upon our first speaker. And I'm sure you all are very eager to listen to him again. Dr. Anil Tendulkar. Please, sir, I invite you to the dais. Also, I invite the chairpersons for the session. Dr. C.S. Hiramat, Dr. Prasanna Simha, Ms. Vasanta Vinodini, Ms. Deepa. Also, Dr. Rashmi and Dr. Anaga, Dr. Balram will be joining us online to chair this session. Thank you.
Good morning, everybody. If you are dreaming anatomy and physiology, then it is called nightmare. Okay? These are not sweet dreams. So shall we start? Basics of cardiopulmonary bypass. I know I'm talking to a crowd of ICU nurses. How many are from the operation theater? Onne, rende. Bas, only 2? Huh? What? No. Only 2. So I'm very sorry. I will have to teach them more than you. Otherwise, they will all, suddenly you will hear sound that she was talking about good sleep. They will say, yes, lecture was very good. I had very good sleep. So any part which you want to operate, whether orthopedic, plastic, neuro, gynec, any operation theater, part which you want to operate has to be steady, not moving. Can you put off the mobile, please? The part which you are operating has to be dry. What is dry? Without blood. Okay? And part which you are operating has to be relaxed. So you can operate only through a small incision. Put a retractor. If the part is relaxed, you can put a retractor, see inside, and you can do the operation. You apply these 3 requirements to heart. Heart should be steady, not moving. Heart should be dry. without blood, and heart should be relaxed, not contracting. What will happen? Patient will die, correct? If this happens, patient dies means actually who dies? Not your beautiful eyebrows and lips. Brain. Okay? Because brain can live only for 3 minutes without any circulation. That is the reason why CPR has to be started. Effective CPR has to be started within 3 minutes. So remember, cardiopulmonary bypass is basically for ayo. Sorry, good. I thought only Ponne Undarka. So hi. So all of you quiet and all are far away. In Mysuru level. So you should be at near Bengaluru. Anyway, so remember, cardiopulmonary bypass is for preserving the brain. So let us start. So what are the various types of heart operation? This you will not see even in brain operations. There are various types of heart operations, and they are basically whether you require cardiopulmonary bypass or don't require cardiopulmonary bypass. In the olden days, cardiopulmonary bypass was not invented. So it was nothing like closed heart and open heart. All were heart operations. But cardiopulmonary bypass was invented, and now we have got closed heart operation and open heart operation. So closed heart operations are PDA closure, MPA banding, full list is been given to it. What is the importance in closed heart operation from ICU nurses point of view? No artificial circulation. Heart is maintaining its own beating, heart is maintaining the body perfusion when the operation is going on. So all the complications related to cardiopulmonary bypass don't exist. As against that, we have got second group of operations where cardiopulmonary bypass is used. What we call open heart operations. Very good. Third is new operations started in 1980s where cardiologists started dilating various valves with balloon. And if they can dilate valve with balloon, if the ASD is small, they could start dilating ASDs also, PDAs also. And reverse of it, yesterday you saw our cardiologist colleague presented device closure of PDA and ASD. Both these, balloon and device, don't require cardiopulmonary bypass. So the recovery is much different than the recovery with open heart operations. And last new thing to come in last 10 years is development of percutaneous valve implantation. Not much in children, yes, they are doing it for pulmonary regurgitation after tetralogy of Fallot. Otherwise, adults, it is very much in vogue. Yesterday, Dr. Jagannath talked about two types of operations, palliative operations and corrective operations. I have purposefully put inverted comma on corrective. They may not be corrective anatomically. They correct physiology. What is correct physiology? Blue blood, all the blue blood coming from veins should go to lung. And all the red blood coming from lungs should go to body. Remember, simple correction. Don't bother it is going through what. More important, blue blood from the body, lung. Red blood from the lung, body. Bus. Don't bother it is going through which wall and which chamber. So these are the basic steps of open heart operation. Don't start writing. If you want, I can give my pen drive to you. There are certain important words which I will make you write. Don't worry. First is opening of chest, the variety of incisions. And nowadays, slowly, we are coming to operating through ports, just like gynec operations, through ports, laparoscopic type of ports. So there won't be any incision. Connect the patient as early as possible to heart-lung machine, HLM. And this is only possible after giving heparin. This you write down. a very high dose of heparin is given because moment the blood comes in contact with non-endothelial surface, blood clots. So blood is constantly checking whether this is endothelium or not. And moment it sees a non-endothelial surface, blood will start clotting. So prevent it. We give a very heavy dose, 3 milligram per kilogram dose of heparin. So post-op problem is if this heparin is not completely neutralized, patient will continue to bleed. Very good. And now we connect the patient to cardiopulmonary bypass. And after 30 or 40 seconds, the perfusionist declares, I am on full bypass. That means what? All the blood coming to the heart is diverted into heart-lung machine. And all the job of oxygenation and pumping is done by heart-lung machine, not by this heart. So if I now stop the heart, will the brain suffer? No. Understood? So that's very, very important that patient is on total cardiopulmonary bypass. So you must know this word, total cardiopulmonary bypass, where all the job, ALL capital, all the job of oxygenation and pumping is done by heart-lung machine. Now we cool the patient. We cool the patient to reduce patient's body oxygen requirement. And that cooling depends upon the kind of operation. Quick operation like ASD may not be cooled only to 32, 33 degrees centigrade. But a very complex operation, yesterday one doctor was showing you hypoplastic left heart syndrome where patient may be cooled to 20 degrees, 22 degrees, like that. So second problem an ICU nurse will face because of this is unequal rewarming. Unequal or incomplete rewarming. Now, after cooling and emptying the heart, we stop the heart by injecting the solution called cardioplegia. Plegia means paralysis. Cardioplegia, paralysis of the heart. Now we open the chambers of the heart. And here you please write down, I might not have written down in the following slides, that we never open pumping chamber. We always open non-pumping chambers. So we open RA, we open LA, we open aorta, we open pulmonary artery. Avoid as far as possible opening of RV and LV. See, a patient with fracture will have plaster, correct? Rest for how many weeks? 3 months. Yes? And Moya will write down, get well soon, heart, arrow. Yes or no? Patient with eye operation will wear goggle. Yes or no? Rest to the eye. But heart, no. No rest. Operation over. Heart has to start pumping fully. Dr. Hiremat will immediately tell the anesthetist, start dopamine, start adrenaline, start this, start that. Intra-aortic balloon pump. We whip the heart. Work, work, work. Heart which is injured, which was stopped without blood supply is not allowed rest. So 99% of the heart operations are without opening the ventricles. This you have to keep in mind. Okay? After finishing the operation, we remove air from the heart. That is called de-airing. And if suppose some air remains, what will happen? Where this air will go? Very good. I'm happy you did not say body. You said brain. Understood? So surgeon very thoroughly removes air from the heart, closes the cardiotomies. This word you must know. Cardiotomy. Opening of heart is called cardiotomy. Atrium will be called atriotomy. Ventricle, ventriculotomy. Aorta, aortotomy. Okay? And once the heart regains its work, its action, we slowly wean off cardiopulmonary bypass. Wean off slowly over a period of say 10 minutes, 15 minutes. We wean off the patient of cardiopulmonary bypass, and then we do exactly opposite. All the steps are opposite. Heparin given, protamine given, pericardium open, pericardium closed, chest open, chest closed, patient brought in, patient brought out. Okay? So these are the basic steps of open heart surgery. This is the basic circuit of open heart surgery. This is a beautiful picture drawn by Dr. Anil Tendulkar the Great. This is called venous cannula. Okay? Attached to, you are seeing the arrow over there also? Good. Attached to venous line. It goes into a reservoir. Reservoir, blood is taken by the pump and pumped through a machine called oxygenator. And the oxygenated blood goes back to the aorta. So this is bypass. What is bypass? Yeah, diverting without changing the destination. If you see matron in the lobby, what you do? You quickly go into Amma, eppadi sirikra? So if you see matron in the lobby coming in your way, what you do? You quickly go into a ward, okay, wait for the matron to go, and then you are back on the same road. Remember. Understand? So this blue blood was supposed to go to aorta after going through the lungs. So instead of going to aorta after going through the lungs, it has gone through the cardiopulmonary bypass circuit. Very good. So this is an oxygenator. This is how it looks like. And though we call it oxygenator, it has got three parts. It has a reservoir. See that on the top, which works like a, should have one pad over here for this. It has a reservoir which works like a atrium. This small part is only the oxygenator. And at the bottom of the oxygenator, where my arrow is heat exchanger, through which the perfusionists rewarm and cool the patient. And they make cardioplegia absolutely ice cold. So there are various types of cardiopulmonary bypasses. Just now, what I told you was conventional cardiopulmonary bypass. Another bypass, for bypass, you saw over here, we have to put tubes. See this? We have to put tubes. So you can imagine small baby, small chest, small incision, and in this small incision, if you put 3, 4, 5 tubes, there is no place for surgeon to do the operation. So what we do, another technique is deep hypothermia. You cool the patient, stop the circulation, remove the cannulae, do the operation, put the cannulae back and rewarm the patient back. Obviously, circulation is stopped and lots of problems because of that can take place. And newer technique has come, is circulatory arrest, but continue the perfusion of the brain. So the first job of the ICU nurse when the patient is received from the operation notes is to find out whether the patient was operated on conventional bypass or deep hypothermia, circulatory arrest, or selective antegrade cerebral perfusion. The brain problems will be different. Okay? And this is just for your knowledge. For your knowledge, as the temperature reduces, the oxygen requirement reduces, and finally, at 20 degrees centigrade, cells have got enough oxygen supply in the form of ATP to withhold without circulation. And this period for which the circulation was stopped is called safe period. So if the patient was operated on deep hypothermia circulatory arrest, you must note down in your ICU notes what was the safe period, what temperature and what was the safe period. So at 37, 5 minutes is allowed. But if this surgeon, Anil Tendulkar, has taken 6 minutes, chance that this brain may not be working properly. Okay? Nothing wrong is going to happen. Surgeon is not going to be taken to police for any inquiry. No, just be aware. For example, at 20 degrees centigrade, 21 to 25 minutes are allowed. And suppose this surgeon has taken 30 minutes, then be aware that surgeon has exceeded the period of safe circulatory arrest. Just be aware. Now let us start a slightly different topic. This is a heart between the two lungs, and the space between the two lungs is called mediastinum. Heard this word? Mediastinal tumor, mediastinal whatnot. So this is a transverse section to thorax, and the part between the two lungs, which you see over here, this part is mediastinum. And who are the members of the mediastinum? Thymus, heart, trachea, esophagus, and descending thoracic aorta. Okay? And the door to mediastinum is basically anteriorly. Posteriorly is vertebra. Posteriorly is vertebra. So this cannot be the door to mediastinum. So the mediastinum is divided into two parts. Anterior mediastinum, thank you very much, sir. Nice of you. So mediastinum is divided into anterior mediastinum formed by the heart and posterior mediastinum, heart, without heart, the other structures. And the approaches to mediastinum are shown over here. Okay, the most common approach to mediastinum is this median sternotomy. You do sternotomy. You have all seen the photograph of Lord Hanumana opening chest and showing first sternotomy done. Remember, still we are finding out how we close the chest, because Hanumana after that flew to Lanka and burnt the whole Lanka. That shows how well the sternum was closed. So all surgeons are trying to do research to find out what material was used to close the sternum and what nutrition ICU nurse gave him that time, by which the bone healed in 2 minutes. Understand? So these are the various incision. This is the second popular incision. Nowadays, I'm sure most of the hospitals, you are doing minimal invasive surgery, minimal invasive cardiac surgery. So second popular incision is right anterior thoracotomy, where you approach RA and LA only. And third popular incision, right anterior thoracotomy, is below the breast and may develop in improper development of the two breasts. So more and more surgeons are switching over to this incision number 5, which you see over here, which is posterior or through the axilla. You approach the heart. Remember, biggest advantage of these are the incisions, how they look like, and the biggest advantage of median sternotomy that you can access all the chambers of the heart. Any operation in the world, including transplant, can be performed through median sternotomy. And all complications can be managed through the same incision, no separate incision for cannulation. So remember, it doesn't look beautiful, but it is very, very safe. So it's few photographs to show you. We use a sternal saw and we open the sternum with a saw, and in a baby, we may use scissor. This is Mayo's scissor to cut the sternum, because most of the sternum is cartilaginous. So we have opened the sternum, all the photography from anesthetist side, because they are very kind enough to allow us to peep inside and use camera. Okay, all my Jomo, Sinmo, they say Ingevenda, Angapo. So they are all photographers, have to stand next to anesthetists, and most of the anesthetists are very kind and considerate in allowing photography. Okay, so you have to now orient yourself of seeing the heart from the head side. So this red fleshy structure which you see is thymus. And we are interested in cannulation to put the patient on bypass. So we are interested in aorta, which is to the right, SVC, which is to the right, IVC to the right. So we remove only the right lobe of thymus. And this is the pericardium, which is open now. And you can see the heart is very deep. So what we do, we take retracting sutures to pull the heart out. Also, by retracting only on right side, we rotate the heart to aorta SVC, IVC are very easily seen. Now we are going to insert special tubes, and these tubes are called cannulae. Cannula, singular, cannulae, official, plural. In India, cannula, plural is cannulas. Okay, so in India it is allowed. लाज आती है लेकिन allowed. Okay, so as I told you, minimum number of cannulae. And what is that minimum number? One for taking the blood to the heart-lung machine. One to bring blood from heart-lung machine, just like your ECMO. Okay, so remember. So to keep the cannulae in place, they should not move. That is the lifeline of the patient during bypass. So these cannulae, to hold them in place, we take a stitch called purse string. Any of you are having a purse with strings? Okay, Ilya allowed a zip. Huh? So these purse strings we pass, and depending upon a lot of science behind that, which we teach our OT nurses, when to use proline, when to use ethibond. So various sutures are used to take purse string. Now, which artery to use? So that depends upon what incision you have taken. These are the arteries which are commonly used. Right subclavian, though it is axillary, subclavian, though it is axilla, actually the incision is below the clavicle. Femoral, you know, is in the groin. Okay? So we choose one of the arteries, surgeon's choice depending upon the incision. So this is the aorta. Again, you are seeing from the anesthetist side. This one is aorta. This is pulmonary artery. This is RA. This is RV. I told you yesterday, though it is right atrium is anterior. Right ventricle is anterior. And left atrium and left ventricle are posterior. Okay, so this is a purse string. Can you see the circular suture? Purse string has been taken on the aorta. And these are the places on RA. We can take purse string for vein. So this is for RA appendage. This is for SVC. This is for IVC. So one of the three or two of the three will be chosen depending upon the case. So all purse strings are taken. This purse string which you see over here with yellow tube is for cardioplegia. All purse strings are taken. Cannulation to be done. Can you tell me? Chocolate. What is the step in between? Amma tungarange pakatle. Hi. Yes. Step between purse string and cannulation. I told you just now. Heparin. You have to give a heavy dose of heparin. And it is given directly into the blood. We don't believe in intramuscular heparins. Intravenous heparin. Okay? And action is quick. Meanwhile, this is very important for ICU nurses. Meanwhile, the entire circuit of that heart-lung machine is filled up with fluid. This fluid is called priming fluid. And perfinists are taught. Any perfinists here? My God, I may ask you a question. They are taught how to calculate what thing to prime. And we prime in such a manner. See, the bottom line is very important. We intentionally want the hemoglobin to 7 to 8 grams. Intentionally. So depending upon patient's hemoglobin, perfinists will decide whether to prime blood or crystalloid. Then we are constantly conscious about the oncotic pressure. So they have been taught to calculate the oncotic pressure. And if the oncotic pressure is low, they will prime albumin or plasma. So remember, on bypass, hemoglobin is intentionally 7 to 8 grams. Okay, all cannulations done. This is the one from the aorta is under this green drape. This is the cardioplegia. This is SVC. This is IVC. And this one which you see over here is called internal suction. So all the blood that is coming into the pericardial field is sucked back into the heart-lung machine, is filtered through 40 micron filter and again goes back. But this blood will contain particulates of bone, particulates of wax, particulates of muscle, calcium, wall. All particulate emboli may be present. If there is a bilateral SVC, we make it sure that both the SVCs are appropriately drained. Now we go on full bypass. In this square, small square, you see this right atrium. Can you see this right atrium? It is full, dilated. Look at me, like my cheeks. Okay? Now, once you go on bypass, see how this atrium has become. See that? So now all the blood is diverted into heart-lung machine. And this patient is on full bypass. This is the aortic cannula, sending blood to body, sending blood to brain, sending blood to heart also. But we want, there are three requirements. I told you, part should be dry, part should be still, part should be relaxed. So what we do, we take a cross clamp and
I think that has got off, sir. Blue.
okay, sorry,
good.
my mistake. Surgeons work with both hands, so perhaps this hand started working also. Okay, so cardioplegia can be in blood or may not be in blood. Accordingly, surgeon will write down sanguineous or asanguineous cardioplegia. Sangua in Latin means blood. Anything A means without. But my name is Anil, so don't think, not even zero also. Okay? Temperature of this cardioplegia is 4 to 8 degree centigrade. So heart will be cold, like you keep food in the fridge. Number 3, heart is stopped and relaxed because of either hyponatremia or hyperkalemia. And all this cardioplegia is sucked into the heart-lung machine. So all the patients on bypass will have hyperkalemia. Please write down. Hyperkalemia, there are some 3 more reasons of hyperkalemia. I don't want to bore you, but please keep in mind, hyperkalemia is a natural tendency of cardiopulmonary bypass. How many of you have got GI drip at the end of the operation? GI, no potassium, glucose and insulin. How many of you? No one? It's very common to start GI drip to take care of hyperkalemia. The most popular cardioplegia nowadays is del nido cardioplegia, which is a hyperkalemic cardioplegia. So if you read in the operation notes del nido cardioplegia, you must know that this patient will have hyperkalemia. There is a time for which the heart can be stopped with a cardioplegia, and with del nido, it is 45 to 60 minutes. So surgeon is supposed to repeat cardioplegia. Remember. So another important thing you have to note down, another important time you have to note down from the operation notes, all ICU nurses will be aortic cross clamp time, also called cardioplegia time, also called anoxic time. How long the heart was stopped. If 2 operations are done, same disease, one in 15 minutes, one in 45 minutes, obviously patient whose heart was stopped for 15 minutes will behave much better than a patient who has been operated for 45 minutes of anoxic time. Understand? We have declared that this cardioplegia is good for the heart. Has anybody asked the heart whether this is good for you or not? Huh? Hiremat has declared that this education is good for you. He has to ask you. That's why he's telling to fill up the feedback form. Understand? So this is what is required. So we must take a feedback from the heart whether this cardioplegia was good for you or not. So remember, bypass time and cross-clamp time, some people call it anoxic time, some people call cardioplegia time, should be noted. And if the cross-clamp time was long, how many times cardioplegia was repeated? That will tell you whether this patient's heart will behave in a good manner or in a bad manner. And just for your interest, to improve your understanding, all these are photographs of ASDs. See this ASD? This is the ASD of fossa ovalis. Yesterday morning I told you. Remember? How many of you were awake that time? Huh? Oh, really? Oh, so nice. Okay. So this is defect of the fossa ovalis. This is ideal for device closure. Okay. But they landed in my hand. What can I do? This is ASD, multiple ASD. See? Can you measure? Lots of ASDs. And see this last bottom? Huge. There is almost no septum at all. Whole atrium, the septum is totally absent. So all sorts of things. My point to tell you, see the field is dry. Can you appreciate? Because of cardiopulmonary bypass. Still and relax. That's why I can put that retractor. Now if I close the cardiotomy, what the heart will contain? Air. Correct? So next job after closing the cardiotomy is to remove air. And all the team except the scrub nurse takes part in removing air. The anesthetist, the perfusionist and the surgeon remove the air from the heart. Please note, there is no foolproof technique of air removal. There is no investigation to tell you air has been removed. It is only the surgeon's judgment. So by chance, if there is little amount of air left in the heart, when the heart starts beating, air will go to brain. Meanwhile, the heart is being closed, perfusionists start rewarming the heart back to 35 degrees centigrade. And yesterday I told you, temperature is required for normal functioning of left ventricle. Okay, this heating is with the help of heat exchanger, water blanket, and some places air warmer may be used in the operation theater. Okay, heart is being rewarmed, operation over, de-airing done, we remove that cardio cross clamp. Can you appreciate? Yes or no? Please keep on saying yes, yes, yes. See, this is a cross clamp. Now, blood will come from the aortic cannula, which will be warm. So, heart which was at 6 degrees, now will become 36 degrees. Potassium, which was 20 milliequivalents in the cardioplegia, now will be 4 milliequivalent. So, heart will start now moving, start beating weakly, and slowly heart will start beating full. Sometimes the heart fibrillates on bypass. Not to worry, we use this internal DC fibrillating paddles, okay, and give shock. Then we give rest to the heart. Heart is getting blood. There is no cross clamp. See at the bottom, can you see the marks of the cross clamp? Even if you don't see, say yes. Can you see these marks? I have put the arrow, just like kiss marks. Now you will see. Okay? And heart is kept empty, but heart is getting blood. It is like full paid leave. So heart is now what is called replenishing the oxygen debt. So this is called rest period. So in your notes, checking in the operation notes, you must find out how much was rest given. Short operation, rest may be just 1 minute, 2 minutes. But long operation, cross-clamp time of 2 hours, 2.5 hours, that rest will be of longer period. Now we wean off. This is going on partial. So instead of 2 venous cannulae, 1 venous cannula, and some blood starts going to heart. See the shape of RA. See the shape of RA? Can you appreciate it is full now? So heart will also start beating. And slowly will wean the patient of all cardiopulmonary bypass. Same purse string is used for tying. And what will he check? I told you, big B RA, amma, bleeding, brain IHA, off bypass, now brain is over. Who is the big B now? Bleeding. So we will start checking the bleeding, and when all the bleeding has been stopped, we will close the chest, try to restore back. Many of these patients are coming for re-operation. So we close the pericardium. And what complication can take place because of closure of pericardium? Write it down. Closure of pericardium can give rise to atypical tamponade. No blood. Moment I said tamponade, you think of blood. No. Tight close. What will happen? Tight close. Will you be able to dance nicely? No. So this is called atypical tamponade. High CVP, low PP. Remember. So surgeon, anesthetists are very alert. They immediately tell us that the CVP is going up, BP is coming down. So we'll not close the pericardium. This is the situation where we don't close the pericardium. Pericardium is used as a patch to close ASD or VSD, extracardiac conduit. So outside the heart, there is one tube. So we will not close the pericardium. Unstable patient. From where they have come? Huh?
The
We are
bus from
already off
Chennai, I think,
bypass.
came now, right?
We are off bypass.
Here, off bypass. I called them, they were stuck in traffic.
And if the
Please sit, please keep moving. Wherever seats available, please sit. I ask you people to
so
be there.
we will see to it. Boys should have been distracted by the girls, but girls to me seem to be more distracted. They are all checking what dress they are wearing, what is the matching, whether it suits her style, that blouse is too short. Everybody is talking that. I could hear that. I could hear. Okay? Or a Cadbury ತರಣ
Please put your mobiles in silent mode, no?
wire cutter. In addition, you can always keep a Mayo scissor. Then all the things will be done in that order. Most important. And patient may require ECMO, so you must have clamps, heavy line clamps.
Sir, another 5 minutes to go.
Yeah, I will do my best to finish in 5 minutes. Now, cardiopulmonary bypass is for good of the patient. But unfortunately, on bypass, these are the problems. These are the physiological problems. Please take a photograph of this. The BP is low, BP is non-pulsatile, hemodilution, hypothermia, heart is empty like a shock, and flow is diverted only to vital organs, not to skin. So, number two, this is the biochemical problem. Blood is in contact with non-endothelial surface. So it is in the form of tubings, cannulae, cardiac wound, gas and bubble in contact, and all this blood is recirculated. So this results in this, what is called contact activation system. And see the bottom, it produces these deadly systems. Complement system is activated, fibrinolytic system is activated, and end result is production of vasoactive cytotoxic substances. There is severe vasoconstriction, there is a cell death, production of inflammatory response. Yes, since yesterday, you must have heard systemic inflammatory response. So patient has malaise. Post-operative fever is not because of infection, is because of systemic inflammatory response. Don't increase your dose of antibiotic. More important, this accumulation of interstitial fluid in all the organs. And there is organ dysfunction. As I told you, depends upon bypass time and how long the heart was opened. And these are the various causes. Please take photograph of this slide also. Various causes why all organs are affected. Circulatory causes, I already told. Embolic, that particles of bone, wax, muscle pieces, platelet clumps, all can go embolize and produce hypoperfusion. On top of that, cytotoxic substances are released from complement system. Spelling is COMPLE, complement system. And these cytotoxic substances damage all the organs. So I have provided, you can take quick photographs of each, how brain is affected, heart is affected in various manners, and most important to you and me is the lung. Various ways lung can be affected. Biggest problem of lung is a spongy organ. So collection of water is far, far more in the lung. Take this photograph also. Non-CPB related causes from intubation to ventilation. So you'll have increase gradient for oxygen between alveolus and blood and decrease compliance. Lung collapses very, very easily. Blood clotting, yesterday she was asking, Amma oda perine? Shanti was asking correctly. So these are the various causes where the blood doesn't clot. So don't keep on giving protamine. You try to find out. And for that, various machines have been brought, like thromboelastogram, which tells you whether the problem is in platelet or heparin or fibrinogen or fibrinolysis. Okay? All the companies which produce oxygenator, cannula and tubings are doing their best to make bypass as physiological as possible. But all these methods increase in the cost of cardiopulmonary bypass equipment. Perfusionists are taught how to make cardiopulmonary bypass as physiological as possible. Okay? So thank you very much for a patient hearing. I hope a surgical topic is useful to you as an intensive nurse. So you know all the things which are committed in the operation theater, all the sins created in the operation theater, you are able to manage in the post-operative period. Remember, thank you very much.
Thank you, sir. Any questions from the audience? I request Dr. Balram Myran from Delhi to be online, please. Yeah, he's here. And Dr. Rashmi from Mumbai. Yeah. Any questions to Dr. Tendulkar from the audience or from the panelists? The floor is open for discussion for a few minutes. Dr. Balram, can you hear us, sir?
Yeah, I can hear you. Can you hear
Yes.
me?
Yeah, yes. Please go ahead, sir.
Okay. Good morning, everyone. And very nice talk, Dr. Tendulkar.
Thank you, sir.
As usual. Only I hope you had some more time because the important aspect of the basics of CPB, that is its aftermath, that you have to hurry up because of the lack of time. So I hope the nurses there who are involved in the post-operative care have noted down carefully what are the side effects of this necessary evil which we have to go through. And I'll ask any of the nurses who can tell me that once the patient comes to the ICU, what specific they will observe in the patient, which may tell them that patient is having the problems because of the CPB in the ICU. What all they will like to observe? Any response from the audience?
Sir is asking, you see the patient in ICU has been just now brought. What problem related to CPB you will observe?
Can you give a mic?
They are saying hypothermia and bleeding.
Well, hypothermia and bleeding. Okay, these are the usual problems.
Hyperkalemia. They are saying, I am not saying, I am only echo.
I can understand.
Intra-theater echo.
See, first and foremost thing, which as Dr. Tendulkar said, you must know that what exactly was done to the patient in the operation theater. What sort of CPB was used. So you must note it down carefully. As the patient gets into the ICU, you should observe whether what is the cerebral status of the patient, which will gradually he will have to wake up. How are the peripheries? Because yesterday it was discussed that the temperature, high temperature, cold peripheries means patient in the low cardiac output state. And you have to be very careful about it. Bleeding, yes. Then anything else you like to see? Blood gases. How are these? Whether there is any acid-base balance, whether this serum lactate is high, what is the potassium like? Then you should have the stethoscope in the ICU. Auscultate the chest. See whether the chest is expanding equally on both the sides, whether the air entry is adequate or not. Sometimes the surgeon just makes a hole into the pleura, but he doesn't put a chest tube. So whether there is any collection on either side, get a chest X-ray as soon as possible to see the position of the endotracheal tube, to see for any collection. Of course, observe all the parameters on the monitor. Gradually, as the patient spends time on the ICU, first and foremost, see the effects of the cardiopulmonary bypass in the form of whether there is any brain problem or not. Patient must get up. He must move all the arms purposefully and equally. Slowly, peripheral pulses should come up. Periphery should get warm up. Urinary output should be adequate. And gradually, the hyperkalemia settles down and blood gases normalize. So all these things you must observe time to time. Look for the drainage, whether it is coming down or not, what is the color of the drainage. Everything needs to be observed and recorded. Anything else?
I just wanted to just tell another point where you can see live the effect of CPB. We describe CPB as a 200% burn for the body. So it is like a burn patient. Now, one of the things that we commonly see is when the patient is shifted is that the PO2s are low. You might have seen that. So as an intensive care nurse, you should be using a lung protective strategy at that time and recruit the lung. So we might have seen, I tell people, give an open lung. What is this open lung? Is to recruit the lung which has got damaged by CPB and collapsed because of non-ventilation, both. And you might have seen as every recruitment maneuver and with lung protective ventilation, the PO2 picks up. So this is a very, very important thing because this preempts worsening of lung function. And if you leave the lung atelectatic and collapse, it will be a problem.
Thank you. Rashmi, doctor, any comments?
Thank you, Dr. Hiremat. And it was very nice to hear Tendulkar sir and Professor Balram sir explain so well to all the nurses and tailoring their talk to all of you. So you're very lucky to hear from giants like this. As a congenital heart surgeon, I would just like to add that all these effects are much more profound when we do it in a neonate or an infant. So the parameters will still remain the same that you'll have to monitor in the post-operative period in the ICU. But just you have to be even more diligent when it comes to smaller babies. Thank you.
Thank you. Thank you, Dr. Rashmi. Thank you, Dr. Balram. We'll move on to the next topic, sir, by Dr. Umed Singh. The topic is ICU management of post-palliative surgery in univentricular patient.
By the time Umed Singh sir comes and loads his slide, patient's PO2 is 120, shifted from OT. Good or bad?
Can you help to Umed side, sir?
PO2 120. What a thing. Relation between FiO2 and PO2?
You know.
So good morning, everyone. Sir, never tired of talking. So good morning, everyone. And where I especially a very thank to the organizing committee to provide me this opportunity. As sir yesterday mentioned that I was supposed to present this session online, but when I went to the browser and the first thing I did when I go search on the Google that what this Muddenahalli is, and then I come to know that is the birthplace of our great engineer, father of Indian engineering, sir, Visvesvaraya sir. So I thought that, okay, I will visit this place in person and I will pay my homage or bow to this great land. One story that is really, you can say, inspired me, and that was told me, I read in a magazine about the Visvesvaraya sir, that once he was traveling in our Indian railway system in the colonial time, and he was accompanied by a lot of our white peoples at that time, the people who were ruling us. So they start to tease him because at that time Indians were not allowed to travel in the first class or like that. So while they were teasing him, they were saying him some sort of commenting on his complexion and all those things. And after some time, all of sudden he stood and he pulled the chain and the train stopped. When all the administration come to him and asked that why did you pull everyone thought that he did this in the disappointment and he was very much annoyed. Then he told that, okay, I feel the change in some vibration in this train, and that might be due to some damage to the railway track. So when the concerned reached there and found that the track was really damaged. What's this? Focus is matter. Rest of the things are not significant. Same thing is true with the people who are working round the clock, taking care of such critically ill patients in the ICU. And you people, since last 1.5 days, we are seeing that you are very, very important person in that time. Because most of time, the critical patient, you are taking the care in 1:1 ratio, and duty SR or the intensivist, he is busy with many other things. So you people are the detrimental for the critically sick patient. So I believe that I came here and I learned a lot of things, but I believe that I will deliver something that will really help you to manage your patients better way. And meanwhile, I will also bow to Balram sir. It's a big opportunity to speak him. If speak in front of him. I always used to be humble, but he is someone. He is someone I can't explain in words. And the work culture he set up, that is phenomenal. So now coming to my talk, I will be discussing about. So it's so okay. Lot of have been told about the physiology and spectrum of that thing, but I would like to mention that as early as 1699, the Chimenu was the guy. What are you doing? It's okay. What happened? The Chimenu was one who found out that the heart may have a single ventricle, that is a heart that is consists of two auricles and one ventricle. It seems very simple, but in reality, it's a very complex congenital malformation, and that have a very wide spectrum that not only challenged our understanding of the cardiovascular physiology, but due to that, many creative brain of the cardiac surgery came with, innovated the most challenging and most demanding procedure like hypoplastic left heart syndrome or the hybrid procedures. So the spectrum is wide, but what sort of the surgery, what sort of the palliative procedure we have to offer them? Rather, as the procedure itself is important, the timing is also that much important. So the stage 1 palliation, which we provide them, that is in the Norwood procedure itself, it may be take place most of time in the first week of their life, or they may be very premature neonates, underweight sometimes, and coming with such a most complex surgery to be provided cared by us. So they may give us really a challenging time. BT shunt, few subset patient require BT shunt. That is also most of time in the neonatal period only. Or also few patients may have increased QP situations where they may be required this PA bending. The next, after the successful completion of the journey through this first palliation, they present for the second palliation. That is in the form of the hemifontan or bidirectional lane. By now, all of us know that in bidirectional lane, the systemic venous flow from the upper part of the body is directed towards the pulmonary circulation, bidirectional in both the lungs. So here the timing is also very important, with the procedure most commonly performed between 4 to 6 months of the age, because due to by that time, the pulmonary hypertension that the newborn born with is settled down. Now the next procedure, third or final palliative procedure, we have to offer them. Of course, heart transplant is there. But that is the Fontan procedure. And this procedure is typically performed. Outcome is better when the procedure is performed at the age of 2 to 3 years. So why 2 to 3 years? Because by the time kid is growing and the volume is increasing. Of course, hypoxia is also a cause, but that is secondary. This increased volume is not handled by the univentricular heart till now we have created. So decrease this volume load. Ultimately, that may increase the preload and lead to the cardiac dysfunction. The procedure is performed between the 2 to 6 years of the age. So we will take this hypoplastic left heart syndrome as a prototype to understand all these palliative stages. Why? because this is the most challenging. Second, there is a platform already set in. Right now, by now, we have seen, yesterday, Dr. Roman presented a very good video. He saw us that what sort of the precautions and what sort of the steps are taken in the hypoplastic left heart syndrome. So for this patient, as we yesterday went through, that the basic principle is the atrial septectomy, where they provide the intermixing, then this intermixed blood, which is saturated equal to pulmonary venous blood only, that is maximum saturation come to the right ventricle. Now this ventricular blood should go to the systemic circulation. For that arrangement, the aorta is enlarged, and to maintain this PA flow, the shunt is added. It could be the BT shunt or Sano shunt. And what extra we have to offer them, that is a hybrid procedure. The principle is same. The atrial septum is dilated, come down to decrease the pulmonary blood flow, PA bending is done, and to maintain the systemic flow, the stenting to the this PDA done. So although these are two procedures, but there is difference in the post-operative management, because in first procedure, definitely patient has gone under the deep hypothermic circulatory arrest. So that patient is going to give us more challenge, or patient might shift with the open sternum and all. So here also, in the previous talk, Balram sir provided us a very, very good platform that from what should we do, apart from the examining from head to toe to the patient, what are the principles we should stay adherent is, that is start from the surveillance of the risk factor and the factor contributing to it. So apart from all the principles, all the protocols we are doing from the rest of the patient, what we do specifically in this subset of the patient is here. It's very clear that the circulation is still in parallel form only. The lungs are supplied by this shunt to be provided. So in that scenario, ventricle has to create the double of the cardiac output, because the same single ventricle, that is morphologically right ventricle, that is going to supply the blood supply to systemic and pulmonary circulation. So ventricle have to work double. So in this situation, already patient went to bypass, and there is bypass related inflammation, swelling, injury, as well as the sympathetic tone is also very high. So in that scenario, to make this ventricle work, we have to use our reserve. In normal patient, our saturation is, we try to maintain in a cyanotic patient the PO2 level of 90 to 100. But in cyanotic patient, what is the cutoff limit? In BT shunt patient, we accept the PO2 as low as 40. So here also, we can accept the PO2 of 40. So for the understand purpose, we can say that in immediate post-op period, we follow this rule of 40. And we manage, our management or our goal is directed that our PO2 should be 40. Same for the PCO2. The PCO2 patient should be 40. Mean pressure of the patient, we target 40 to 45. And the hematocrit, that is also 40. So we try to strike a balance where all those things, all those vital parameters and investigations stay around this 40. So what we do, what we have to do this, either this is the balance between systemic and pulmonary circulation, what we are trying to manage. So for that, what we have, we can manipulate the SVR or PVR of the patient. So what we have in our hand to manipulate the SVR, specifically we can use in this patient is, if we require vasodilatation, we can use inodilators or phosphodiesterase inhibitors. The available literature suggests that most common use are the milrinone, or we can use alpha blockage, that is phenoxybenzamin. So these are the things we use to manipulate the systemic vascular resistance. Or for PVR, what to do? We can, since previous talk, we have learned by now that there are various ventilatory studies. By that, we can adjust this, we manipulate this pulmonary vascular resistance accordingly.
Yeah, Umed, you have 5 more minutes.
Okay, sir. Now, what extra we do? Monitoring. So, in this particular patient, we do this systemic venous oxygen monitoring, and our target is to keep it below 45. And there is a gradient between the systemic and arterial and venous oxygenation that should keep low. And what extra we do is multi-site NRS monitoring. In multi-site NRS monitoring, with the help of that, we can calculate non-invasively the QP-QS ratio. So it was for the hypoplastic left heart syndrome. Now, how a typical rest of the patient who require a BT shunt, how typically they present. So here, if we see this patient, the patient presented in the emergency, and we can see that at the presentation, what was the saturation of the patient? It was 36. And after that, your job start in casualty itself, where the cyanotic spell was managed. And here, look at the VVG of the patient, the pH of 6.9 and the lactate of 13. So they are very, very sick patient. I'm trying to show you these things because we are going to handle this patient post-operatively, so we know what exactly the situation patient have faced in the pre-operative period. Here the patient was admitted and intubated and put on the NORAD, and the surgery was planned. So at the time of the surgery, what the surgeon will look on, he will see the CT angio, and here we can see that the arch. I just wanna explain that how heterotaxy, how the complex the congenital anomaly could be, that patient is having simultaneously DRV, this hypoplastic RV, then the look at the great arteries. The arch is on the right side and the mirror branching of the. So these are the technical challenge. According to the patient, the surgeon will decide that where the stent should be placed. And we should also know about all those things. So when the patient land up into the ICU, so here we can see that this was the PO2 of the patient, 32. So as we discussed in the previous session, that we all do all the things, lung recruitment and all those things to bring down this PO2 thing at least up to 40. So these are the things, meticulous things that you people keep doing continuously. Initially, you can see that we are doing this everything every second hourly. And this is your chart, which really give us real-time information that what sort of the inotropes and all those things you people are giving. So it's very important thing for us. So finally, after doing all those things, this was the monitor of the patient, where we can say that at the almost this mean pressure of the 40, we were able to maintain the required saturation that is in the range of 75 to 85. And this was the on 31st when I was planning to leave. This was our AVJ finding that was quite optimal. So after discharging, when the patient for the stage 2nd palliation, what we have to offer them? Gland or heavy fountain. So what is the post-operative management principle is? We try to separate them from mechanical ventilation as early as possible. Why? Here we can see that in the spontaneous ventilation, there is in one phase of the respiratory cycle that during inspiration, there is a negative intrathoracic pressure, and that help to the passive return of the blood from the upper part of body to the lungs. So we try to separate them early from the mechanical ventilation. Here we can see in this particular study, they point out that the parameters which are suggestive of the increased systemic perfusion as well as cerebral perfusion were increased significantly when the patient was separated early and at the 30 minutes after the separation from the mechanical ventilation. But what we do if we are not able to separate the patient from mechanical ventilation, what will be our strategy? Yesterday there was a good discussion on that what will be the PCO2 level we will maintain in these patients. For shunt surgery, it's very clear that we maintain the CO2 lower side. But for gland surgery, what literature suggests that in the various loop of this in our body, that as we know that CO2 causes this cerebral vasodilatation, simultaneously it causes pulmonary vasoconstriction, that which feedback loop take over the another. In this scenario, the cerebral vasodilation loop take over to the our pulmonary vasoconstriction loop. So we try to maintain a PCO2 towards the higher side if we are ventilating a patient mechanically post-glen. And here we can say that all the parameters were better when we were keeping the PCO2 in the range of 50 to 55. Same with the, sir, I have 2-3 more slides.
Yeah.
This is then the present for the third stage. The principle is same, and also patient vary from patient to patient. So what option we have? Ventilative strategy in this patient, either we can provide them the this negative pressure ventilation with the help of this coronary ventilation or the iron lung, but that is not feasible possibly for practically, or this is the our APRV mode of the ventilation, in which the when the inspiratory stage of the respiratory cycle, there is negative intrathoracic pressure, and patient there is passive increase in the blood flow of the lung. Complications, there are many. I will not go in them much. One important aspect, the CPR. While doing the CPR of these patients, what is the how it's different from the rest of the patient? Because here there is no, in the glen, there is no blood when we are giving the success, there is no blood flow to the lung. It's depend on the active recoiling of the chest, the blood coming to the lungs in this Glenn and Fontaine procedure. So the chances of success in this patient CPR go down significantly. And second important aspect is where the heart is exactly locating in the univentricular patient. So in this study, they found that in infants and neonates, either we give compression at the intermammillary line or below a lower half of the sternum. But here, the heart is located in most of the patient in the lower third of the sternum. So this could be a cause of the less success less success rate for CPR in these patients. And so in urgent opening of the chest and treatment of arrhythmia or use of external pacing and shunt thrombosis and all those things kept in mind while we are resuscitating these patients. So this is my last slide. After all, the communication with the patient, that is also very, very important aspect. And that should be very much open, frank, but simultaneously sensitive as well. Because the patient, these patients are going to have very poor prognosis. And not only the communication with the patient, at the communication at the time of taking over, that should be also on the same level. We should remain updated that at what level, what sort of the thing already have been communicated with the relative and from where we are supposed to start. So these are the another aspect of our care that is really, really very important. Thank you.
Thank you. Thank you, Dr. Umed. I think in lack of time, no questions will be taken. We'll move on to Dr. Iyer's talk. Dr. Krishna Iyer, who's the director and chairman of Fortis Hospitals, New Delhi, is there online. The topic will be on open sternotomy and delayed sternal closure. Dr. Iyer, you are there, sir?
Yes, I am here. Very good morning, Sairam.
We can't see you. Can we get Dr. Iyer online, please? Shivakiran, can you get Dr. Iyer? Yeah, we can see him. Yeah. Yeah, good morning, sir. Welcome, sir.
Good morning, Sairam.
Yeah.
My talk is recorded, I think, so you can play that.
Please go ahead, sir.
It's a recorded talk, no? So can you play that? Or do you want me to?
No, we'll play, sir. Yeah, we'll play and you'll be there, sir. We'll take the questions. Yeah.
At the outset, I'd like to thank the organizers of the International Nursing Conference on Pediatric Cardiac Intensive Care for the opportunity to participate in this symposium. I apologize for not being there in person. The topic I have been given is deferred sternal closure. My name is Krishna Iyer. I'm from the Fortis Escorts Heart Institute in New Delhi. Now, deferred sternal closure has been in vogue for many, many decades. The first publication that I could find where deferred sternal closure has been mentioned was published in 1975 by Rihai et al. But subsequently, there have been publications by the Texas Heart Group and Cooley in 1978, and a case report by Gangahar al. in 1981. But in the last few decades, deferred sternal closure has been used extensively in most congenital heart units which practice high volumes of cardiac surgery. What does open sternum or deferred sternal closure do physiologically? It increases the volume of the pericardial space, reduces cardiac compression, and improves cardiac output. It increases the pleural space, allowing for better ventilation. It reduces the impact of positive airway pressure on venous return and therefore improves cardiac output. It allows for packing with gauze in case there is uncontrolled non-surgical diffuse bleeding. It allows rapid access to the heart in the ICU in case an immediate intervention or drainage of the pericardial cavity is required, and also in patients who require mechanical assist in the form of an LVAD or ECMO requiring central cannulation, then the sternum has to be left open. Sternum can be left open electively in the operating room, which we call primarily. In case of an event in the ICU requiring opening of the sternum, then it's a secondary deferred sternal closure. Therefore, the common indications are mostly related to hemodynamic instability resulting from low cardiac output, which can be because of myocardial edema resulting either from prolonged myocardial ischemia or a suboptimal myocardial protection intraoperatively, can be a result of arrhythmias and occasionally a regressed ventricle in, for example, a situation with delayed presenting transposition of great arteries. Uncontrolled bleeding, especially non-surgical, is another indication for a deferred sternal closure, and as I mentioned, mechanical support and lung issues. Occasionally, in situations where an extracardiac conduit has been placed in a neonate or a small infant, it may not be possible to close the sternum immediately because of the myocardial swelling and resulting compression of the extracardiac conduit. This illustrates how in our unit we practice deferred sternal closure, how we manage the open sternum. As you can see here, the sternum is open in this situation. You can see the heart beating underlying. The sternal edges are kept apart with a piece of chest tube, which is sutured to the edges of the sternum. This acts as a splint, preventing the sternum from coming together and also allowing for external cardiac compression in case that is required. And then we cover the area with, it can be done with celastic membrane, but that's expensive. And we have found a cheaper alternative, which is a sterile blood bag. So you cut out a piece from a sterile blood bank, which is readily available in the blood bank, and then you can suture that to the edges of the skin. This gives you a clear, transparent window to be able to see whether the blood is collecting underneath or not. And then the whole area is then covered with a sterile dressing with a window cut out in between for us to be able to observe the heart through this window. It's important that all sterile precautions are taken. And in fact, we try to create a mechanical barrier, which is transparent, of course, by using a cling film across the child's chest in front. At the end of the requirement, the sternum needs to be closed. So how do we time the sternal closure? Importantly, of course, the indication for the deferred sternal closure has to be reversed, which means that the cardiac output has to be normal. Any mechanical support in the form of LVAD or ECMO would have to be weaned off. The lung function would have to be optimal, so ventilatory pressures have to come down to acceptable levels. And if bleeding was the indication, then bleeding should have been controlled. And again, the sternal closure can be done in the operating room or in the intensive care unit, depending upon unit policy and feasibility. It's important that when we approximate the sternum, we wait for about 10 minutes to observe the hemodynamics and continue with definitive closure only if the hemodynamics remain stable. Deferred sternal closure is not without its complication. Then the most important complication is infection, which can be in the form of surgical site infection, mediastinitis, or sepsis, and been reported with the incidence of 3 to 18% in this collective review. These patients would require prolonged ventilation because patients would have to be on the ventilator till the duration of the open sternum at least, and it increases the hospital stay by an average of 9 to 10 days in most units, thereby also increasing hospital costs. In the US, the average cost might go up by as much as $137,000 per patient. This patient also would require deep sedation, and therefore it ends up with prolonged narcotic use, which has concerns of long-term issues. And these patients are also associated with higher mortality because the underlying condition is likely to be more complicated. The surgery would be probably more complicated. And the need for deferred sternal closure means that they've had significant complications. So quite a few publications on deferred sternal closure, which have been published in the last few years. I've just picked up a selection just to illustrate some of the issues connected with deferred sternal closure. Now, this is a collective review from the STS Congenital Heart Database, which focused on infections in patients with deferred sternal closure. It's a large cohort of more than 6,000 patients out of a total of 90,000 infants who were operated over a 6-year period. As you can see, the majority, 66%, belongs to STAT 3 or 4. And in their study, they found that the infection rates are much higher in patients with deferred sternal closure, 18.7% versus 6.6% for those patients who did not have deferred sternal closure. Also, they found a correlation between the incidence of infection with the duration that the sternum was left open. And beyond the 3 days of sternum being left open, the infection rates continue to climb significantly. This was a paper from Mumbai, from the Kokilaben, Dr. Suresh Rao's unit. And there they compared the patients who had elective sternal closure vis-a-vis patients who had to have emergency sternal closure in the ICU. And then they showed that in the patients who required an emergency opening of the sternum in the ICU, the mortality was very high, 71%, as compared to those patients who had elective deferred sternal closure, where the mortality was only 11%. And as you can see that these are the indications for emergency opening in the ICU. Most of it is related to hemodynamic instability, occasional cardiac arrest, and arrhythmias. This is a paper from All India Institute of Medical Sciences again. 63 patients who underwent deferred sternal closure, and this table illustrates the various indications for which the sternum was left open. Myocardial edema and unstable hemodynamics being the commonest, non-surgical hemorrhage being next. Patients requiring ECMO were 14%. Those requiring prolonged CPB with poor lung compliance were 11%, high inotropic support, and conduit compression or other indications for leaving the sternal open. As you can see, the all-cause mortality in their incidence was 19%, which is much higher than the mortality for routine patients. This patient from Mexico again illustrates the various risk factors which were significant in patients who underwent deferred sternal closure. Importantly, it was lower age, female gender, pre-op use of inotropes or need for mechanical ventilation, a higher RAC surgical score, higher CPB times, and higher aortic cross clamp times. These are all associated with deferred sternal closure, and these patients had a higher mortality, so 22.4% versus 8.7% in those in which the sternum was closed. Again, the commonest indication of the subgroup of pathologies in which deferred sternal closure was required was transposition and TAPVC, which form almost half the population of those requiring DSC. An important, interesting finding that they had in there, that as the age increased of the patient, hemodynamic instability became less and less as an indication, and bleeding became more as an indication. So the patient was less than 8 years. Hemodynamic instability was a more common indication for DSC. With more than 8 years, the bleeding was the more common indication for deferred sternal closure. Some units use deferred sternal closure very liberally because they managed to reduce the incidence of morbidity and mortality. And this group from Children's Hospital of Los Angeles published their data on 1,000 patients undergoing deferred sternal closure. They have a policy of liberal use of deferred sternal closure, and they justified it because their mortality and morbidity was much less than what is reported by the STS congenital heart surgery database. So in their case, the mortality was only 6% in this group as compared to 18% in the other, and the incidence of infection again was 6% in the form of wound infection. So they concluded that a liberal policy of DSC does not adversely affect surgical outcomes, including infectious complications, and therefore DSC should not by itself be considered as a source of morbidity and should be used with the slightest of indications. I had the opportunity to write an editorial on this issue, talking basically on whether or not to do deferred sternal closure as a routine. And the important thing was that when you utilize a preemptive intervention, it can use it either very liberally or too conservatively, depending upon the perceived benefits and disadvantages. And this is the case in deferred sternal closure, because if we take a decision in the operating room based on an assessment of the expected post-operative course, and if that hemodynamic deterioration occurs in a patient with a closed sternum, then you've lost the opportunity for a proactive intervention. And therefore, it's a difficult question to answer whether you should routinely leave patients with an open sternum or not. But it's important that when one does leave the sternum open, that all protocols are followed in order to prevent sepsis, because as I mentioned, that is the major complication in this. So this being a nursing conference, it's important that strict protocols are laid out for each unit and they should be followed strictly. So all patients preoperatively should be treated as though they may have a deferred sternal closure, and therefore it's important that skin cleansing, MRSA screening, as well as chlorhexidine baths prior to surgery, and use of preoperative antibiotics according to unit protocol as prophylaxis. Also important post-operatively, when they are kept in the ICU, that they should be isolated in isolation room or in a restricted area with restricted entry of staff. When staff is handling the patient, they should be masked and use gloves if they're touching the patient. And the incision site should be adequately covered with dressing, and proper care of the dressing should be done. When these patients require echocardiography, which is often required, then it's important that the probes are cleansed with cleansing wipes, as well as sterile gel should be used. Again, when you're closing the sternum, if they're closing it in the ICU, then it's important that area should be converted to the same sterile techniques that are used in the operating room. So to summarize, deferring sternal closure is a useful strategy to overcome perioperative low cardiac output, respiratory complications, or bleeding-related issues. But it's not without its own complications, so judicious use is warranted. And unit-level protocol should be formulated and implemented to reduce complications related to deferred sternal closure and thereby extract maximum utility from this life-saving intervention. Thank you very much, and questions are welcome.
Thank you, sir. Thank you for finishing on time. Any questions from the audience? Mike, give the mic to her, please. Kindly introduce yourself and from which place or institute you are coming also. Can you give the mic to her, please? Yeah, please stand up. They can't see you. Yeah, thanks. Put it on. Tap the mic and see. No. It's working, please.
Hello, Shanti from Jimma, Pondicherry. How long sternum can be kept open, sir? For how many days maximum?
There is no limit. You have to keep the sternum open as long as the reason for which you have left the sternum open has been reversed. So if it is a low cardiac output, then the patient's cardiac output should have normalized before you can close the sternum. If the bleeding issues, bleeding should have been controlled. By and large, in most institutions, the sternum generally would not require to be opened beyond 5 to 7 days. Because beyond the third day of leaving the sternum open, infective complications incidence rises sharply. So the question is not how long it can be kept open. The question is, what are the risks of complications the longer that you wait with the sternum open? So when you have a sternum open for a longer period, it obviously indicates a bad outcome for the patient. So there's no time limit that we can leave the sternum open only for 5 days. So we will close the sternum at 5 days, irrespective of what the patient condition is. So it's not like that. So it's like a ventilator. Now, how long can you keep a ventilator? You keep a ventilator till as long as the patient needs it, whether it is 3 days or 3 weeks or 6 months. But as you know that the longer you keep a patient on artificial support, then the higher is the incidence of complications and lesser is the incidence of survival. So it's the same with deferred sternal closure. There's no time limit. It's as long as it's required.
Is it necessary to give sternal wash, sir, every day? If the sternum is kept
Sorry?
open with that blood bag cover.
Shanti, mic to be close. You should
Hello?
hold like
Is it
a
necessary
cone,
to
ice
give,
cream cone, you know, hold it close here like
Yes,
this.
sir.
Then he can hear. Otherwise, they can't hear.
Sternal wash is mandatory, sir, if the sternum is covered with that blood bag cover or anything.
What is mandatory? Sorry.
No,
Sir,
no,
her question is, sir, she's asking whether do we need to give every day sternal wash?
No. You don't open the dressing. You don't open the sterile cover unless there is a collection inside that you need to drain or you are ready to close the sternum.
Okay, sir.
I think the sternal washes are
Necessary to keep the baby sedated or paralyzed, sir.
very often the sternal wash is given because the patient is bleeding and there are clots which are there. That is the commonest indication. In fact, one of the options is to put a suture a Ziploc bag. Ziploc bag, which you see, and you can open the zip and you can close the zip. That makes it easier for inspection if required. But unnecessarily opening is also not recommended.
Sir.
Yeah.
Regarding sedation and paralyzing the baby, sir.
Patients need deep sedation and muscle relaxant.
Okay.
Yeah. Thank you, Shanti.
Thank you,
I think Dr. Rashmi, I wanted to make some comments on Dr. Umed's talk. Yeah, go ahead, Rashmi, please.
Yes, thank you, Dr. Hireman. One tip to all the nurses on ISR's talk is, as Sir has emphasized the necessity for sterile techniques to be maintained even in the ICU. As nurses, all the activities that you all do on a baby in the 24 hours, try to group it to one time rather than, repeatedly touching the baby every 10 minutes or 15 minutes. Try to do many things at one time when you handle this baby. This helps you to handle them less in a 24-hour cycle, like ABGs, feed, change, all this you can try to get it in one go. Few points I wanted to tell is that I think as nurses, you all will be seeing a lot of post-operative Glenn surgery patients in your ICU. So things to watch out, as he told, was definitely saturation, which will not be very high. 75 to 85 is what we're targeting. But if you see a drop, please inform early. Be very keen for rhythm disturbances, which is quite often seen in these children. As nurses, please auscultate the lung periodically so that you pick up collapse and effusion early. It helps in the management of the Glenn. And SVC syndrome, because of the kind of surgery we have done, the children are prone to developing swelling of the face, head, and upper 1/3 of the body. That's something as bedside nurses, because you're constantly with the baby, you can pick it up earlier than a visiting consultant. And when you're handling the lines, you should be aware most of them still have holes inside the heart. So make sure you do not push air when you are handling the lines of these babies. And even if maybe your intensivist or the surgeons forget, you have to remember that there's a Glenn line, which it's good if it is removed at the earliest. So please keep a watch on that. And they may drain for a longer time than your other patients. So positioning and physiotherapy is vital. Watch for chylothorax. It's that milky fluid that you see in the drains, which can be seen after the Glenn surgery. And accordingly, there will be some medications and most importantly, feeds that will be changed. And you have to maintain the compliance of the feed as a nurse. Lastly, please don't forget aspirin, which will be advised to these children, and not to miss these doses in the post-operative period. Thank you.
Dr.
Thank you.
Hireman?
Yeah,
Dr.
please go.
regarding Dr. Iyer's talk, I think he has highlighted regarding the post-operative care of all these patients very nicely. Only, Dr. Iyer, can you highlight also for the benefit of the nurses, in case the patient requires CPR, then what all special precautions are to be taken in the patients with the open sternum?
Yeah, thank you, Dr. Balram. Nice to see you. As I had shown in that, one of the things that we do is to put that splint in between. That splint is a sort of slightly rigid plastic tube. So we take out a portion of the chest drain, which is fairly stiff, and suture it to the edges of the sternum. So it serves two purposes. One, it of course prevents the two edges from coming together. And secondly, also in case one needs to give CPR, then one can do that without much risk of the edges of the sternum hitting against the heart and causing cardiac injury. So one can do conventional CPR. It's important that one should not be as vigorous as one could be with a closed sternum. So a little more, should I say, gentle CPR, but you can do CPR as is required. The second, of course, is when they have an open sternum, it's very easy or relatively easy to quickly open the sternum. You just have to cut across the membrane and the splint, and you can do internal cardiac massage. So we have also trained our nurses to do internal cardiac massage in case the surgeon is not available at that point of time. So these are the two options. One can do conventional CPR and one can do open chest massage. Both options are available. Of course, open chest massage is preferable if there's a surgical team around. But if there's nurses alone there without the doctor, then an external compression can be done. That's where the splint is very important.
Okay, thank you.
Thank you, sir. We have our intensivist, Dr. Kamoji, Vishwanath Kamoji, who has joined there online. Any comments, Dr. Vishwanath?
Yes, thank you. Thank you very much, all the speakers and very esteemed team assembled online as well. It's a question to Dr. Umaid, and I think all the nurses will also be asking the same questions. Are you able to hear me?
Yes, sir. Yeah, he's there, sir. 1 minute.
The question.
Put the mic on.
The question which is asked by the nurses is can I bag this baby, and whether it is with oxygen, especially the glands, and whether I bag this baby with an inline suction or I take this tube out, disconnect from the ventilator and then bag. How do we assess the situation, managing this saturations of 75 to 80%? I'm sure you'll be very keen to know what exactly is to be done at that time.
Sir, in our practice, in such small babies, we don't do the practice of inline suctioning. But if they require airway cleaning frequently, first thing we will assure the adequate sedation, because definitely they are the patient who are requiring prolonged mechanical ventilation. We are not able to separate them. So in that scenario, under adequate sedation, and when we are doing this bag mask thing, our tidal volume should not be that much, because also I have mentioned in that CPR slide, due to lack of time I was not able to mention, this ventilation, hyperventilation is also very, very critical, and that should not be done. So during that gently delivering that adequate tidal volume to for the patients, such 4 to 6 ml per kg, we should do this airway cleaning under sedation.
Lovely. And do you use oxygen during this bagging, or do you just use...
Sir, the bag is already connected with the TP circuit. There are modifications as well, and as well as we can use this bands or the long TP circuit that are that vary from setup to setup. And with the help of that, we can adjust the that flow accordingly. So most of time we put it. We practice it that we keep that flow 4 to 6 liter, and then we'll do. And that we have the open end of the bag, sir. From there we can control that how much air is getting mixed and how much FiO2 we are actually delivering to the patient.
Thank you. Thank you.
Yeah, thank you. I think we'll move on with the next talk, sir. Thank you. I'll call upon Dr. Anil Tendulkar. on the topic on handling of sutures during cardiac surgery. In fact, he was refusing to give the talk, telling that only 2 cardiac scrub nurses are there. But I told them that even the ICU nurses handle sutures. So do you want his talk to be cancelled or to be kept? No. Everybody is telling to be kept, sir. Please. There are online also, sir, sisters who are there on cardiac ICU scrub nurses. You can keep it simple and safe, sir, as you do always.
Has the count of number of OR nurses increased? Before you came, it was 2. Anyone from OR?
They are there. See, they're there from Jaidev team came. How many are OT scrub nurses now? Can you raise hands? 2, 3. But sir, about the sutures, they should be knowing, sir, no problem.
Chalo. He has told me to keep it simple, so I will keep it simple. So when we say suture, every suture consists of.
Where the slides, sir, slide.
I can see myself. Okay. So every suture has got 2 parts, needle and the strand. What we call suture is actually strand. And the needle has got 3 parts. The tip of the needle, the body of the needle, and this spot, whether all vascular sutures are joined to the needle in such a manner that the diameter of the needle and the diameter of the strand remains the same. Strand could be of different types. So let us start with the tip. There are various tips. These I have chosen only the 4, and the bottom, the top one, taper point and taper cut are only the sutures used in the operation theater. And in ICU, if at all, you will require taper point suture. So the suture which you buy for cannulating an artery or vein will be taper point. Okay. For skin and subcutaneous closure, you will require conventional cutting suture, needle. That's the third one is the conventional cutting needle. Now the needle has got variety of things. One is needle length, and different companies measure needle lengths differently. One step before that, you can have straight needle, you can have curved needle. Straight needle you can use with fingers, curved needle you require a needle holder. And the needle length are measured differently. One company measures it from the tip to the swatch point. This is they call cord length. While the needle can also be needle length can be also be measured along the curvature. So so you must ask the surgeon what needle length is required. The needle could be of various curvature. For pediatric operation theater, we require this half circle needle. But in ICU, for purse strings or for cannulation, you require 3/8 circle needles. There are 2 types of strands available. Proline is compared with our hair, smooth monofilament, but very, very delicate. As against that, we have got braided suture, just like your pinnal. It's braided, it is strong, but the surface is rough. For all vascular suturing, we use Proline. So most of the sutures that you will order for ICU will be Proline. Now let us come to the swatch point. This is a typical what we do at home. When you are thinking of suturing, obviously cannot be done for vascular suturing, and most of the modern vascular sutures are swatched in this manner. And the current technique, with a laser, you make a hole in the needle base, and in that needle base, under microscope, workers pass a suture and fix it. Now this is the most important slide. All of you should take photograph. This is what you see, so many things written. and what you are interested in the strand type. So here the strand type is proline. Number two, strand diameter. So strand diameter is 7O. This is empirical. Somebody started 0. So below 0 is 10, 20, 30, 40, 50. So now currently for blood vessels, we use 70. But in ICU, for cannulation, etc., for stitching, etc., I think 5O and 6O proline also will do. Then next is strand length. How long is that thread? And here you can see the strand length is 75 centimeters. Next is the needle, needle material, needle diameter, needle tip, needle length, and needle whether at one end of the suture or at both ends of the sutures. All this together makes one code. One thing is changed in this, the code is different. So don't just say 7O or 6O. You must know whether this surgeon, this intensivist requires this particular needle length, this particular proline, this particularly long suture. So all this is into one code. So best thing is to know the code. Okay? The company people will always try to deceive you by saying, sister, this is 6O only, but the needle, the length, the curvature, the tip will be different. And your intensivist will start complaining that this is not the suture that is required. The suture should be nicely stored, and if you are consuming good number of sutures, companies usually provide you with this stands, should be away from heat and should be kept in a dry place. Most of the companies have a peel-off wrapper. You know peel-off wrapper? Correct? And the peel-off wrapper, the middle two fingers, you keep it on the inside suture and give it to the operator who is cannulating. So the inside wrapper, inside of this, what you see over here, this is sterile. Inside is sterile. And this is eco-friendly. It's a recyclable plastic. Other sutures required is this monocryl. For skin closure, you must have in ICU as well as vicryl. For closure of the subcutaneous tissue, you must have in ICU. 3O vicryl, of course, as I'm telling you, I'm telling only the strand. I'm not telling you the needle. And similarly is 3O monocryl for subcutaneous closure. So, tips about handling of suture: read the labels properly, read the expiry date, rotate the stocks. So if a new stock comes, keep the new stock below and the old stock should be on the top. Or don't bring out the new stock till the old stock is over. Open only when sutures are really required for procedure in hand. And most important, the instrument which you use to hold the needle should be according to the needle, according to the suture. So if you are using 7O, 6O, the needle holder should be also appropriate for 7O, 6O. Remember, simple logic, delicate needle holder. And if the needle holder is this long, don't give this long forceps. The surgeon will be, the intensivist will be outside the ICU and holding the forceps, while the other hand will be inside. So very commonly made mistakes just because they are available. So I always give example of Amitabh Bachchan and Jaya Bhaduri. So always Amitabh Bachchan should have equal Amitabh Bachchan height, or Jaya Bhaduri should have equal Jaya Bhaduri height person. The needle should be loaded. If you are assisting that intensivist, the needle should be loaded only by the tip of the needle holder, right in the center of the body. Don't go near the tip. Don't go near the swatch. These are delicate spots. Some do's and don'ts. Don't put rubber band like this. There is a chance that the needle may puncture the foil and may come out. Okay, even this is not allowed. Everyone is smiling and laughing. So I'm sure you must be using. Even the rubber band is the glove. You cut the glove, hand of the glove is cut and used, correct? Best is sticking plaster. Anywhere, everywhere, use sticking plaster. Then, if leftover suture, India is improving, India's economic status is improving. So leftover sutures don't put in Sidex or alcohol. Okay, alcohol weakens the surrounding structures and damage the suture. Okay, as I told you, always hold the needle in the center of the needle. Don't try to go near the tip of the entire aspect of needle is the tip of the needle, the penetration of the needle. So if you damage the needle tip, you, including the surgeon or the intensivist, damage the needle, it will be bad. Same thing, all the monofilament sutures like proline, monocryl, they are very delicate sutures. So if you hold it in needle holder, that suture will be crushed like this. And when you tie it, the tie will break. Or if it doesn't break now, with 120 pressure inside the artery, one day it will break and form an aneurysm. Do not autoclave sutures. Okay, these are all synthetic material. They will form into the clumps. Do not soak in Sidex. Sidex is a one great holy water in ICU where urine catheters, suction catheters, everything is kept. Still available? No. Many Indians do no like this. So we don't know yes or no. Okay. So equally important is complaint handling. Most of the companies actively encourage you to lodge a complaint that they feel improves their product. So most important for complaint handling is this, that initial thing which you saw is they are more interested unless you provide this. Your 7 breaks, they will not do anything for that. But if you tell them that this code number, this suture, this batch supplied by you on this day broke, that they will have to attend immediately. They make you the answer saying that we found nothing, all other batches. Sister, only you are complaining. There is no other complaint. No other hospital is complaining. It's a standard thing. They say, yes, you should tell them, yes, we are bad. That's why we are complaining. See, only living human beings only complain. Those who are dead just never complain. Okay? And most important, the hospital must insist on complaint ID for following up the complaint. But just by telling the company person, "Arey, your 6O is useless," just will not help you anything. That initial picture which I showed you, that is far more important, where on that pack was that this, on that pack, this batch number, etc. written, this part, this tells you the batch, etc. This is very important to them. Okay, this is all basic, sir, short and simple suture.
Thank you, sir. Thank you so much. Should you have a tea break, sir, or no tea break?
Sure, tea break.
We'll assemble back in 10 minutes.
Are
tea
you
is ready downstairs? Tea is ready? Yeah, thanks. Tea is ready, 10 minutes. Come back fast. Very important topics are there for the to remember. Thanks.
Water. You're giving to somebody? I'm keeping here.
Madam, sorry. How is the child not doing well?
Yeah, I spoke, the pulmonary edema is there, ET bleed is happening. Yeah. There's no pointer, right?
No pointer. So, ma'am.
Yeah. Yes.
Hmm?
Next.
This one.
Hello. Hello.
Working. No.
Good evening. We'll start with the next session. Hello, silence please. The session 5 will be on the topic of cyanotic spells, where Dr. N. Arvind, the pediatric cardiologist, will be speaking. I request Dr. Tendulkar to come on stage, please, as chairperson. We have online Dr. Ikshu Dhanwa from Palwal, Delhi, the cardiac surgeon working Sathya Sanjeevani Institutes at Palwal. He is there online. And also Dr. Madhu, cardiac anesthetist from Mumbai, he is there. Over to Dr. N. please.
So once again, a very good morning to all of you. At the very outset, I want to thank Dr. C.S. Hiramat sir for giving this opportunity and platform to interact with the distinguished faculty of this field, be it from India or across the globe. We are very grateful to you, sir. And be it 1 week long Healing Little Hearts Pediatric Cardiac Care Camp, where we do intensive pediatric cardiology and pediatric cardiac surgery work, or it is these academic forums, his endeavors have always ensured that our career growth takes a fifth gear. Thank you, sir. So now I'll be speaking on topics cyanotic spells, the pathophysiology and management. So cyanotic spells are one of the defining features of the fallotetralogy and the like lesions. It is defined as a paroxysm of hyperpnea with progressive increase in the rate and depth of breathing, irritability and prolonged crying, deepening cyanosis, limpness, syncope, and occasionally recurrent or prolonged cyanotic spells can lead to convulsions, cerebrovascular accidents because of the cerebral venous sinus thrombosis, and death. Usually the cyanotic spells are self-limiting. In mild cases, the post-spell somnolence is characteristic. There may not be any precipitating cause, and spells are not necessarily related to the degree of cyanosis. The peak incidence is 2nd to 6th month of life, and occasionally we see cyanotic spells even at 1 month of age and beyond 2 years of age. So the congenital heart diseases that are associated with cyanotic spells include the physiology lesions like tetralogy of Fallot, pulmonary atresia with VSD, double outlet right ventricle with VSD and pulmonary stenosis, transposition of great arteries with VSD and pulmonary stenosis, single ventricle like tricuspid atresia with large VSD and pulmonary stenosis. So can anybody tell me what are the 4 components of tetralogy of Fallot? I know it's a very simple question, but for the sake of interaction. Yeah. VSD, can you, do you want to elaborate on VSD? What kind of a VSD?
Give her the mic, please.
Large VSD, non-restrictive VSD. Yes, yeah, good. So we'll spend some more time on pathophysiology. So let's say you have a tetralogy of Fallot baby. Let's say he's a 6-month-old baby and the blood pressure is 85 by 55 millimeters of mercury. So what is the LV systolic pressure in this child? The blood pressure is 85 by 55. LV systolic pressure would be? Yes. And RV systolic?
Large VSD. Large VSD. So large VSD. So
it's a non-restrictive VSD. So when in the presence of a non-restrictive VSD, there is an equalization of systolic pressures between the left ventricle and the right ventricle, right? So the right ventricle systolic pressure in this baby would be 85, right? So now we can consider heart as a single chamber that pumps blood to the systemic and pulmonary circuits in tetralogy of Fallot from physiology point of view, right? Okay. Now the ratio of flow to the pulmonary and systemic circuits is determined by the ratio of pulmonary resistance and systemic vascular resistance. So the next question, how are pressure, flow and resistance related to each other in an equation? Pressure is equal to, blood pressure is equal to flow into resistance, right? So that means the blood flow is inversely related to the vascular resistance in that bed, in that circuit. You understood? Yeah. So we have this equation QP by QS is equal to systemic vascular resistance by pulmonary resistance. where blood flow, because we said that blood flow is inversely related to the vascular resistance. So QP by QS, which is the pulmonary blood flow by systemic blood flow, will be equal to the systemic vascular resistance and pulmonary resistance. In tetralogy of Fallow, the pulmonary resistance is fixed, right? Why? Stenosis is there. So in fundibular or valvular stenosis is there. That is a fixed stenosis. So it becomes a constant. Okay. And what will be the systemic blood flow in tetralogy of Fallow? It will be the pulmonary venous return that is coming to the left side of the heart plus right to left shunt across the VSD. So both these flows will constitute the systemic blood flow. So whatever is coming from the pulmonary veins to the left heart plus the right to left shunt across the VSD, both of this in combination, they form the systemic blood flow. So from this equation, we can say that any change in the systemic vascular resistance would determine the magnitude of the pulmonary blood flow and the degree of right to left shunting across the VSD. So systemic vascular resistance is the main determinant. Are we on the same page? Got it? Yeah. So with this understanding, so whatever factors, whatever the precipitating factors or whatever triggers a low systemic vascular resistance will lead to increased right to left shunt across the VSD and a decreased pulmonary blood flow. So we see this diagram again. Systemic vascular resistance decreases. So when the resistance in this vascular bed decreases, what will happen? More blood will flow. Blood has a tendency to flow towards a low resistance. So more blood will flow from right to left. Correct? So more deoxygenated blood is coming to the systemic circulation. That would result in hypoxia, hypercapnia, and acidosis. These factors, they stimulate the sleep-sensitive respiratory center. The respiratory center is more vulnerable when the patient awakes from the deep sleep. So after that because the the respiratory center is activated, so there is hyperapnea. There is increased rate and depth of breathing. That will result in negative interthoracic pressure. Because of the negative interthoracic pressure, it will result in increased systemic venous return. So systemic venous return to the right side of the heart. Correct? Because you have a negative interthoracic pressure, so increased systemic venous return to the right side of the heart. And because we said that systemic vascular resistance was low, so there will be again right to left shunt across the VSD. So we have a vicious circle. Yes. So present, and also the presence of, there is a fixed resistance here, as you all told me that there is a fixed RVOT obstruction here. So low systemic vascular resistance, increased right to left shunt, and fixed pulmonary resistance, all of this will precipitate the cyanotic spell. You want me to repeat that again? Yeah. So what are the triggers? So all the precipitating factors or the triggers which are going to decrease the systemic vascular resistance. So whether it's feeding, crying, straining, increased physical activity, or fever. So what happens is there's a sympathetic stimulation and there's a release of the endogenous catecholamines that will cause tachycardia and increased cardiac output and low systemic vascular resistance, because blood pressure is equal to cardiac output into the systemic vascular resistance. So when cardiac output increases because of the increased sympathetic stimulation, the systemic vascular resistance will decrease and trigger cyanotic spell. Next, the supraventricular tachycardia and the rapid atrial pacing. What happens when there is a tachycardia? There is the diastolic filling decreases. Stroke volume decreases because diastolic filling has decreased. So the stroke volume will decrease. And because there is tachycardia, so oxygen demand has increased. Correct? So this will trigger cyanotic spell. Then hypovolemia and dehydration. So that causes infundibular narrowing. It precipitates infundibular narrowing. And there's a reduction of blood pressure because of the dehydration. That also increases the right to left ventricular shunt because the blood pressure on the systemic side has decreased. So right to left shunt will increase, and that will trigger the cyanotic spell again. ACE inhibitors, anesthetic agents, cardiac catheterization, these are some of the factors which decrease the systemic vascular resistance and can trigger the cyanotic spell. Role of infundibular spasm. So that decreases the pulmonary blood flow. So everybody knows what is infundibular? So how are pulmonary valve and aortic valve related to each other? So pulmonary valve is anterior to aortic valve because it rests on a muscle. What is that muscle called? Infundibulum. So pulmonary valve is resting on a muscle which is called infundibulum. And in tetralogy of Fallot, that infundibulum gets anteriorly deviated, causing the right ventricular outflow tract obstruction. So when there's a spasm of that infundibular muscle, because it's a muscle, it will decrease the pulmonary blood flow and divert the blood flow into the aorta, right? Because RVOT obstruction has further increased because of the spasm. So this as an initiating event for the hypoxic spell is still controversial because pulmonary valve stenosis has a fixed resistance. In addition, the infundibular stenosis, which consists of disorganized muscle fibers intermingled with fibrous tissue, is non-reactive to sympathetic stimulation or catecholamines. So some studies say that infundibular spasm does not play a role in triggering the cyanotic spell. Occurrence of cyanotic spells in pulmonary atresia, where there is no flow across the pulmonary artery, argues against RVOT spasm as the underlying mechanism for the spell, because we do have the cyanotic spells, we do observe the cyanotic spells even in patients who have the pulmonary atresia VSD. So this is from the theoretical point of view. There are certain theories which have postulated the mechanisms of the cyanotic spell. I won't go too much into detail. So because whatever we have discussed, that is just named on basis of these theories. So Wood's theory says spasm of infundibulum of right ventricle leads to decreased pulmonary blood flow, progressively increasing right to left shunt across the VSD and thus initiating the cyanotic spell. Catecholamine release, that's another theory which leads to increased myocardial contractility and infundibular stenosis. Gunterroth's theory says hyperapnea is actually the cause rather than the effect of the cyanotic spell. So hyperapnea we discussed because there's a negative intrathoracic pressure, so the systemic venous return increases and right to left shunt increases and it triggers the cyanotic spell. Morgan's theory says vulnerable respiratory control mechanisms, which are especially sensitive after prolonged deep sleep, react to the sudden increase in cardiac output provoked by feeding, crying, or straining. So this also we discussed. Young's theory says atrial tachycardia precipitates the hypoxic spell. So we have a recent theory by Dr. S.S. Kothari, which argues against the other hypothesis, and he suggested the role of stimulation of mechanoreceptors in the right ventricle to be the cause of the cyanotic spells. Increased contractility due to catecholamine and decreased RV size can trigger a reflex resulting in hyperventilation, some peripheral vasodilation without bradycardia, and this may initiate a spell. So when we talk about the management of a cyanotic spell, it would be to break this vicious cycle, okay, by increasing the systemic vascular resistance, increase the RV filling so that more blood goes towards the pulmonary circuit, and simultaneously decrease the catecholamine production by relieving the pain and anxiety. So let's say you are on night call, you are in your ICU, and the floor nurse, your colleague, calls you that a patient who was waiting for tetralogy of Fallot complete repair surgery 2 days later has become sick, has suddenly become very blue, is crying. So what will you instruct your floor nurse to do? Knee chest position, yes? Yes. Yes. Okay. Yeah. So many steps, you have come forward with many steps for the management of cyanotic spells. So you will calm the child and relieve pain and anxiety. Okay. So that will reduce the release of the endogenous catecholamines and it will decrease the heart rate. And a trigger of the cyanotic spell. Knee chest position, as you said, and other squatting equivalents. So how does knee chest position help in relieving the cyanotic spell, in breaking that cycle of pathophysiology of cyanotic spell? Yeah. So as we discussed, the first thing that happens in a pathophysiology of cyanotic spell is decreased systemic vascular resistance. So whatever your floor nurse or whatever the attender can do at that point of time is to keep the baby in the knee chest position, knees and hips flexed to the abdomen. So that is for the infant. Usually the older children, they adopt the squatting equivalents. Yeah. So it increases the systemic vascular resistance, as you said, and that will decrease the right to ventricular shunt, right to left shunt across the VSD, and then it will break the cycle.
Annie, you have 3 more minutes to go.
Okay. Then it traps the venous blood in the lower extremities, decreases the systemic venous return, decreases the right to left shunt across the VSD. So somebody said 100% oxygen. It has a role, but a limited role, because reduced pulmonary blood flow is actually causing the hypoxemia here. And then IV bolus of a crystalloid, NS bolus, 10 ml per kg. You can ask your floor nurse what is the weight of the child, and she can give 10 ml per kg NS. So the mechanism is mentioned. It will increase the RV preload and push more blood towards the RVOT, fixed RVOT. Then 0.1 to 0.2 milligram per kg of IV morphine. Sodium bicarbonate intravenous, 1 milliequivalent per kg, that will correct the acidosis and eliminate the respiratory center stimulating effect of the acidosis. Ketamine has an effect on the systemic vascular resistance. It increases the SVR. So beta blockers. Yes. IV esmolol, which is a short-acting beta blocker, 0.5 milligram per kg over 1 minute. IV metoprolol or IV propranolol can be used. So beta blockers, how do they help? They lower the heart rate, improve the diastolic ventricular filling, increase the RV preload, and improve the cardiac output, and acutely increase the systemic vascular resistance by antagonizing the vasodilating effect of the beta adrenergic stimulation, because we told that endogenous catecholamines have released during this process. So if it is still unremitting, the cyanotic spell is still continuing, then you give systemic vasoconstrictors. So phenylephrine, it will cause alpha adrenergic stimulation. It will increase the systemic vascular resistance and decrease the right to left shunt across the VSD and improve the oxygen saturation. The dose is mentioned as slow IV bolus of 5 to 10 microgram per kg, followed by 1 to 5 microgram per kg per minute, or norepinephrine in an IV infusion of 0.05 to 1 microgram per kg per minute. Okay, so sometimes even the cyanotic spells, the patient has a medically refractory cyanotic spells. You have tried all the medical pharmacotherapeutic measures, but the cyanotic spell is still continuing. So in that case, we take the baby for the emergency surgical intervention, systemic to pulmonary artery shunt like systemic to pulmonary artery shunts like, okay, the more common that we do, BT shunt. Okay, or if the patient is amenable for the complete repair, the baby is taken for the complete repair. Then second is percutaneous RVOT stenting, which is an alternative strategy for emergently improving pulmonary blood flow in TED spell, so that the surgery can be undertaken later once the child attains a favorable state. So often in the OPD, the parents will come, that patient is crying too much and he will turn blue. Is that a cyanotic spell? No. So more often we see the patients coming in the OPD with a history of breath holding spells. So it is important to distinguish between the two. It is a behavioral disorder, which is an attention seeking behavior. It is also a paroxysmal episode of short, loud cry, followed by sudden involuntary holding of the breath in a forced expiration. The child may become apneic, cyanosed, rigid or limp, followed by long-awaited inspiration and resolution of the spell. Usually it is self-limiting. And the child is well otherwise. In between the episodes, the child is well. And he is a healthy infant. So prevention, often the etiology of fallow patients We give oral propranolol at the dose of 0.25 to 1 milligram per kg thrice a day to reduce the recurrence of spells, and especially if the definitive surgery is delayed. A high prevalence of iron deficiency has been observed in children with TED spells. This may indicate a potential role of iron therapy in decreasing the frequency of spells. So many of the prescriptions of the TOF patients you would have seen, the doctors have prescribed two medications, main medications, propranolol and iron. Yes. So parents need to be educated regarding the recurrent nature of the spells and to avoid precipitating factors, and you need to teach them the knee chest position. Yes. Timely corrective surgery prevents the long-term complications of the cyanotic spells. Thank you.
Thank you, Dr. Ani. We have Dr. Madhu from Mumbai, the cardiac anesthetist and intensivist. Can you come online, sir? And also Dr. Ikshu Dhanwa from Delhi. You are there online? Any questions? Any questions from the audience? Yeah, he's Dr. Ikshu from Palwal, Haryana. Dr. Madhu, are you there? Yeah. Any questions, any comments, Dr. Ikshu? Yeah, Madhu is there, yeah. Can go ahead, sir.
I think Dr. Ikshu is speaking something.
Ikshu, you need to unmute yourself. Hello? We can't hear you. Kindly unmute. Yeah, please go ahead, sir.
Yeah. Sir, regarding the palliative procedures, BT shunt was mentioned. I think our nursing staff should know about the cyano shunt also, which is also being done quite extensively these days. So I just wanted to mention about cyano shunt, which is an RV2PA shunt in cases of pulmonary atresia. And at times we also do Brox to increase the size of the PAs, so which can be used as an alternative to BT shunt. I just wanted to mention these two procedures.
Yeah, thank you for that inputs. Dr. Madhu, yeah.
Yeah, that was a wonderful lecture, man. We covered most of the things. But whenever the patient is in cyanotic spell, I think the immediate response is to calm the child. I think morphine and ketamine plays a very good role in this, where morphine can has a favorable effect on the pulmonary vasculature also. It sedates the child also. And ketamine, after sedating the child, increases the systemic vascular resistance also. I think these two drugs, if used in the early stage, will help in controlling this cyanotic spells.
Yeah.
One point I want to make also as far as nursing care is concerned is when cyanotic children are given a bath, and if you give a warm bath to these children, that can trigger a spell. So you should not use too hot this thing when you are trying to give a bath to the baby. And even the mother has to be educated not to give a very hot bath. This is typical, our Indian tradition is to give a hot bath and put oil and put it in the
massage and
all that and keep it in the sun. This is it's okay for another child, but for this is one thing, and very commonly this is how a spell is triggered. So, so nursing, these things have to educate the parents about it.
Thank you. Thank you, sir. I think we'll move on with the next talk. That is by, thank you, Dr. Ani, once again. Very good discussions. By Dr. Snehal Kulkarni, who's the senior pediatric cardiologist from Mumbai. Her topic is on duct-dependent circulation in critical heart disease, the role of cath lab. I think it's a recorded talk. Dr. Snehal is there. I think she's out of the country. She was traveling, she told us. Can we have the recorded talk, please? Shiva? Yeah.
Good morning, everyone. And I will be speaking on role of PDA stent in a newborn and how do we do that and what are the different approaches and what we need to do in the cardiac catheterization laboratory. As you know, when we do the PDA stent, we do in situations where the pulmonary blood flow is PDA dependent. That means there is a pulmonary atresia-like situation and we need to have PDA for survival and improving the pulmonary blood flow in that setting. So there are two types of situations where we do the PDA stenting. One is a duct-dependent pulmonary blood flow. And those are the situations, especially tetralogy of Fallot with pulmonary atresia, intact ventricular septum, or any kind of a single ventricle with pulmonary atresia where PDA is essential part for a pulmonary blood flow. We have to keep the PDA open. You know, there are two approaches where we can do. One, we can do a BT shunt, to have a connection between aorta and pulmonary artery so that there will be pulmonary blood, pulmonary blood flow. But nowadays, instead of doing a BT shunt like surgical procedure, we try to keep the duct patent open so that it will serve the same purpose as the BT shunt does. And we have another situation where we need a PDA patent, where PDA is a part of a systemic blood flow. So these are called as duct-dependent systemic blood flow like situations, and they are typical hypoplastic left heart syndrome, interrupted aortic arch, and severe coarctation of aorta, where we require the PDA for a systemic blood flow. As we know the neonatal physiology, usually the PDAs remain open for 24 hours or 48 hours after birth, and after 48 hours or sometimes even very early, they completely close. And if they close, either the pulmonary situation or the systemic situation, circulation can be at jeopardy, and therefore the duct has to be open to keep the systemic or a pulmonary blood flow in circulation. So when we try to do PDA, stenting the PDA in the cath lab, we should know how we assess the patient before the procedure. Of course, a detailed echocardiographic anatomy has to be assessed. The important part, what we look at on echocardiography, is what are the sizes of branch pulmonary arteries, because that decides what is the size of the PDA stent which we are going to implant into the duct. Another very important part, that there should not be significant narrowing of the origin of the branch pulmonary arteries. I will show you some pictures what happened, because if there is a narrowing at the origin of the branch pulmonary arteries, there is a chance that our stent will selectively go in one of the pulmonary artery, and the other pulmonary artery will not have enough blood flow, and that will get completely cut off or narrowed over the period of time. And the third very important point, especially from the procedural point of view, what is the origin of the PDA? Because that decides the axis. I'll just talk about that. What are the different axes we try to take when we try to stent the PDA? Now suppose we are planning a procedure of PDA stent in the cath lab. How do we stabilize the baby? We do this procedure in newborns. So they're very unstable. Their oxygen saturations may be in 50s or 60%. Then the weight wise, they may be 2.5 kilo or 3 kilos. So we have to be very careful in stabilizing these babies before the procedure. Many times this happens, they come in a collapse-like situation after 2 days, because as I said, the PDA can close. And when the PDA closes, the baby just collapses. And they come in a shock-like situation where we have to start prostaglandin infusion immediately so that the PDA will open. And the dose of prostaglandin infusion is between 20 to sometimes 40 or 60 micrograms per kg per minute. Usually, we always try to use as less dose of prostaglandin as possible because it has its own side effects. Many times, one of the most important side effects of prostaglandin is the babies develop apneic episodes, like they stop breathing. And if they stop breathing, we have to put them on ventilator. Even before shifting the patient from one center to another center, if we start prostaglandin infusion to keep the PDA open, there is always a high chance that the baby may become apneic and may need a ventilatory support while transfer itself. So we have to be very careful when we start prostaglandin. It has to be the baby has to be in the ICU and continuous monitoring to see for the apneic episodes. So therefore, we always try to use as low dose of prostaglandin as possible, just to increase the size of the PDA. So the dose is between 20, 40, or sometimes we may go up to 100 micrograms per kg per minute. And we try to keep the saturation at around 80, 85%. So usually before the procedure, maybe for a day or so, the babies are on prostaglandin infusion. But when we take the patient on for a procedure, just before the procedure, 1 hour before the procedure, we stop this prostaglandin infusion, because for the procedural sake, we need to have some constriction to the duct where our stent will be holding properly. So we stop the prostaglandin infusion 1 hour prior to the procedure. because it's a stent, to keep the stent open and it should not thrombose, we have to give aspirin. So we start aspirin usually 1 day prior to the procedure. So we give around 3 to 5 milligram per kg. Sorry, not per minute, per kg per day. So if the baby's weight is around 3 kg, we give around 10 milligrams, so 3 to 5 milligram per kg per day. So we give 1 day prior to the procedure, and we give in the morning. Suppose we do the procedure at around 10 o'clock. So on the day of procedure in the morning also, we give the dose of aspirin through the nasogastric tube. The procedure is usually done on general anesthesia because any kind of a complications can happen. So we just prepare the baby as if the baby may need even a emergency BT shunt if the procedure doesn't go well. So therefore, we do the procedure on under general anesthesia. Keep a blood ready always. Put the baby on arterial line, internal jugular line. Prepare exactly like a BT shunt. Even we keep our inotropic infusions ready. Usually they may require adrenaline infusion, so we keep the inotropic supports ready. And we have different accesses. I will tell you which are the different accesses, and the access depends upon what is the anatomical location of the PDA. So what are the things to be kept ready in the cath lab when we take the patient into the cath lab for the procedure? Some ultrasound machine. The babies are small. Many times many times their arterial and venous lines are fired because of multiple attempts of puncture. They may be in the shock-like condition. And many times in nowadays we use ultrasound machine to get ultrasound vascular accesses. So therefore, ultrasound machine has to be ready. Even we keep a echo machine ready because while doing the procedure, sometimes we have to see what is the position of the PDA, what is the position of the stent, how is the flow to the pulmonary arteries. Another drug, in addition to heparin, sometimes we may require urokinase because sometimes we get in a situation where there is an acute stent thrombosis. And if there is an acute stent thrombosis, the drug which is used to dissolve the thrombus and keep the flow growing is urokinase or streptokinase. Inform always the surgical team and keep the OR ready, because in case of any complication happens, even we may not have time to really shift the baby from the cath lab to the OR and get the things ready. So inform always the surgical team that they need to be ready in case any complication happens. So what during the procedure, we usually give heparin 100 units per kg. So suppose the baby is 3 kg, we give 300 units. Usually, the action of heparin lasts for 45 minutes, and we have to repeat heparin after 45 minutes. So always keep a record of heparinization timing and write there that at that particular time you have given, because during the procedure sometimes we are engrossed into the procedure and we may forget the heparinization time. So always keep a record of that. Check ACT. ACT has to be between around 200 to 250 seconds. ABG has to be repeated after the procedure to see what has happened to your PO2s and lactates. Keep a watch at the access site. So we may need the child to be ventilated for 24 hours because suddenly we increase the pulmonary blood flow excessively. So baby may need ventilation. Repeat ACT every 6 hourly, because even after the procedure, we may continue heparin infusion at 10 units per kg per hour for 24 hours for two things. One is we want our stent to be patent. And the second thing, sometimes in the procedure, we may lose the arterial access because there is a spasm of the artery and a formation of a thrombus. So we should not lose the arterial access. So for both these issues, we keep the babies on heparin infusion 10 units per kg per hour and keep a record of the ACT every 6 hourly and keep the ACT at around 200 to 250 seconds and adjust the heparin accordingly. And the hardware which is used for the procedure, usually whatever hardware which is required for doing coronary angioplasty, that hardware is required. Puncture needle, gel gauze, wire which passes through that, We require sheath which is 4 French or 5 French, mainly 5 French, mainly because our guiding catheter goes through 5 French sheath. RCA coronary diagnostic catheter, 0.035 or 0.032 guide wire to cross, the guiding catheter, coronary wires, and the stents of different sizes, 3, 3.5 or 4 millimeter coronary stent, and which depends upon the weight of the child. Mainly because if the weight of the child is 2.5 kg, we use a 3 millimeter stent. If the weight is around 3 kg, we use 3.5 millimeter stent, and if weight is about 3 kg, we use 4 millimeter coronary stent for a procedure. What complications we expect? We expect some complications. Sometimes the access are very difficult. Sometimes if the PDAs are very tortuous, crossing the PDA can be difficult. PDA can go into spasm. We may have to start prostaglandin infusion. After putting the stent, the stent can get thrombose and there can be a clot formation. As I said, we have to use prostaglandin, urokinase infusion to dissolve the clot at that particular time. Sometimes the stent embolization, because when we put the stent may not be sitting in the proper position, it get embolized. And the PDA is a very fragile structure. And in the process of our catheter wire manipulation, dissection of the PDA can happen and it can really become an emergency. And as I said, we may have to take the child for surgery in that situation and need a ligation of the duct and BT surgery. So as I said, see the different axes. The PDAs come from different parts of the aortic arch. So this is coming from undersurface of the aortic arch, this one and this one. This is coming from the descending aorta. This comes from base of the innominate artery, and this comes straight from the descending aorta. So these are the different origins of the duct. And depending on those origins, we have to take different axes to cross the PDA. I have discussed all these things. What are the different steps? What are the things which are required? The guiding catheter, introduce a sheath, the wires, then the coronary stents. If we have to remove a stuck-up guide wire, the micro catheter. So these are the hardware which is required. And we have to be very selective about our assessing the patients, about the case selection. Echo assessment is a must. Sometimes prior to the procedure, we may require a CT angio to decide about the size of the PDA, how it is originating from the aortic arch. Aspirin has to be given prior to the procedure. Investigations, the sepsis and necrotizing enterocolitis, which is very common association, they need to be ruled. We have to rule them out prior to the procedure. And I have talked about the prostaglandin infusion. I will talk about the axis, which can be a different axis. See, this is a child which is in the cath lab, and the axis has been taken through the carotid artery, actually. So now, this is, I'm just showing you some patients. This is a 1-month child, hypoplastic tricuspid valve, hypoplastic RV, and almost pulmonary atresia, PDA-dependent blood flow, and the PDA is coming from it's a horizontal PDA coming from the descending aorta. So this approach, we have passed through the catheter through the femoral artery, and we are putting the stent across it. This is another patient, tetralogia fallow, long segment pulmonary atresia. And if you see, the duct comes from the undersurface of the aortic arch. And here, this PDA is stented through the right axillary artery. So this is how the stent looks after after putting the stents into the PDA. And we always see to it that we do a echo every day. See, the saturations have remained around 83%. The PDA stent is in situ with good flow across branch pulmonary arteries. This is a third case, 11 days old, tetralogy pulmonary atresia, tortuous PDA from the undersurface of the aortic arch, where you see this is a PDA. And now here what we have done, you see The PDA is coming from undersurface of the aortic arch, but the axis what we have taken is from the left axillary artery. So as I said, it always depends upon from where the PDA is arising from, and this axis is from the left axillary artery. This is a branch. These are the branch piece, and this is a stent which we have put through that. This is another patient where we did a stenting through the regular axillary approach. It did not work. So this axis is through the right carotid artery. So sometimes we have to take surgical help for exposure of the carotid artery and put a sheet across it. And this is a stent which has come through the sheet which is put in the right carotid artery. So this is the way we put it, and this is a stent across it. Again, you say the pre-discharge echo, the stent is in position where to check that saturations are 90%. So what decides the axis is a ductal origin. What are the ductal types? I'll show you what are other things. So sometimes the duct come from the descending aorta, where we go from the femoral artery. Sometimes this is a vertical duct, comes between the two arch vessels. So either can go through the right axillary artery or from the carotid artery. This is a duct which is again from the aortic arch, but very close to the left subclavian artery. So we can go through the axillary artery for this approach of the stent. And this is coming from the base of the innominate artery, and this duct can be addressed to the femoral artery approach to engage the duct and put a stent. So these are some of our data where we did it in almost 30 patients, and the complications can be ductal spasm, dissection, stent thrombosis. Sometimes because of the excessive flow, they go into reperfusion pulmonary edema, vessel damage, bleeding, arrhythmias, and these can be some of the complications. So ductal stenting is a preferred choice for as a palliative procedure in cyanotic congenital heart defect. There is a significant evolution in last 2 decades. To assess the ductal morphology is the key. And sometimes if we can't decide on echocardiography, we have to take help from CT angio to decide the vascular axis, and that determines the procedural success. Thank you very much.
Since it's a record talk, no questions will be entertained. Now we'll go on with the next session. That's the panel discussion. I invite the panelists, Dr. Uma Nambiar, Dr. Adil, who will be joining us online, and Mr. Vivek Sinha. The moderators are Dr. Karthik Ramesh and myself. I request Karthik Ramesh, who is a AI master. In fact, he's the top AI masters in the world, 50 top AI masters in the world today. And he will listen how AI can be utilized in nursing care. That's what the discussion happens. I welcome, yeah. Thanks. Madam Uma Nambiar, she's a neurosurgeon. We'll have a brief introduction first. Yeah. Dr. Adil is there, Shivkiran. Dr. Adil is there online. Can you get him on? Can you see the screen? Dr. Adil, good morning.
Yes, yes. Good morning, doctor.
Yeah, good afternoon, everybody. And first of all, Sairam, thank you to Sadhguru Madhusudan Sai and Sri Madhusudan Sai Institute of Medical Science and Research for giving this wonderful platform and opportunity for bringing esteemed speakers. And also, of course, our dear Dr. Hiremat, CS Hiremat, yet another event, sir. Congratulations. I think this is becoming a global platform. And today's topic is on the role of AI in nursing education and pedagogy. But I'll be failing in my duty. You'll have to excuse me, I'm running a sore throat. I have some very illustrious people on the screen and in person here, and I need to introduce all of them to you. And also a very warm welcome to all the students, the nurses. In fact, my mom underwent a surgery a few days back, and I'm here because of a nurse. A very good nurse is taking care of my mom at home. So really appreciate and salute what all of you do. So I want to start off with introducing a very, very esteemed person. There is one similarity between all these speakers on the screen, including Dr. C.S. Hiremath, who's next to me. Great people don't need an introduction, right? Their good tasks, their activities speak about themselves, speaks volumes. So I noticed none of them have a formal profile anywhere on internet, or Dr. Uma has not updated her profile for last 5 years. But she often shares a lot of inspiring stories of how so many nurses have been the pillar and the center point of healthcare administration. So Dr. Uma is currently the CEO of Indian Institute of Science, Bangalore Medical Foundation's Bakshi Parthasarthi Hospital, which is almost, I would say, a 2,000 crore in valuation hospital, supported by Tata Trust and also by Bakshi Parthasarthi, the founders of Mindtree. And she's also a very senior neurosurgeon who has been, a very long introduction I found, but she told me this introduction is 5 years old. So she has around 45 years of experience in various hospitals. She's worked in, Gym Care Hospital, where she was driving the helm of affairs. She's been a healthcare administrator. She's been a former technical advisor to the Minister of Health in Djibouti. She's worked in international projects in Botswana, Africa, Sri Lanka, India. And she also serves as a chairperson of the Digital Health Association of India. She's an executive committee member of telemedicine. So maybe, Dr. Uma, I know now why you don't put an introduction. It's so much to speak. So I can speak for 40 minutes just on that. She worked also with Sri Chitra Institute for Medical Science and Technology, and she has fellowships from Mayo Clinic from Paris, and she's done her MBA from Faculty of Management Studies at Delhi. Dr. Uma Nambiar, is a proven, I would say, a doyen in digital transformation. And welcome, madam. And I want to give you also a little news about her, that she's a great artist. So when she's not, running hospitals or doing research in Indian Institute of Science, it's an honor and privilege to have a role model, I'm sure, especially for all the women. More power to you. I have, again, a very close friend of mine, and who is currently the managing director and CEO of the Bangalore Bio Innovation Center. Thank you, Dr. C.S. Hiremath, for ensuring that Dr. Adil joins here virtually. Dr. Adil is a PhD from the Indian Institute of Technology, Madras, and he's done some advanced research in genetics, and he will talk about it during the panel discussion. So the BBIC is run by the government of Karnataka, and it comes under ITBT and KITS. So it's a very renowned institution which is at the cutting edge of life science research. Last but not the least, I also have with me today another person, as I said, who has not put any introduction, and I was literally asking him, why did you not do this, right? Why did you not have a proper introduction? But again, a very illustrious career, and he's also we are from the same alma mater. He's from a former batch, senior batch of Indian School of Business. And Vivek Sinha, welcome. This is your second time here in Muddenahalli. It's a great honor and privilege to have you. He is the founder and CEO. Now, this is going to be interesting to all the students and all the nurses here. He's the CEO and founder of Mversity, which basically is a digital platform which upskills, reskills, and also offers nursing education, right? So he's doing this day in, day out. He has more than 15 plus tie-ups with universities. Now, what is more interesting is before here, joining in Mversity, before founding Mversity, he was a very senior person in Unacademy, right? So he was like playing the role of COO. He has been a senior executive at OYO for their luxury hotel strategic business unit. And he's also worked on Build-A-Czar after his stint at ISB when he did his MBA, working with very top private equity firms. Recently also got the GSV award. It was recognized with multiple accolades. So it's an honor and inspiration also to have you, Vivek, here today. Thank you for taking time, because I know you spend all your day with, with nurses and, So on that note, welcome again, and I will Before I ask Dr. Hiremat, CS Hiremat to ask the question to Dr. Uma, maybe I'll start with Vivek himself. So Vivek, what was the inspiration, moving from An Academy, right? And all of these private equity, venture capitalist firm backed, you've been hugely successful, right? Last 10 years. What made you take up this role of training and, doing such a noble profession of upskilling nurses, which is the need of the hour? Tell us that story.
Thank you for having me here. And first of all, congratulations to all of you who are a part of this great institution. It's my second visit to the institution. If the first time I was totally inspired. So when the invitation came to me to be a part of this, I could not have said no. I actually canceled a trip to be here to meet all of you. Thank you for bringing me here. The story of why I started Mversity. If I be completely honest, I had I would say a very humble background, not even from a semi-urban area, but from a proper rural area. So when you come from that sort of a background, or let's say when you come from scarcity, then what is the first thing that is in your mind? Money. So in the first part of my career, first 5 or 7 years, all I did was chase money. I did everything which I believed, which will take my family from, let's say, a certain strata in the society to a 1 or 2 notches above. God was very kind. Maybe I also did something good. That in the initial year of my career, I saw good success, even when I was working as a professional or when I worked on my 2 previous ventures. Built, I would say, a moderately successful venture, sold it. But in this stint of my life, I realized that it's something more than just success and money. This time it had to be meaning as well. So when I quit an academy, I was looking for ideas. I was thinking about what should I do? What should I devote the next 15 or 20 years of my life on? It has to be impactful. It has to be meaningful. And it was during then when I spoke to a person who is now a mentor to us. He's the founding dean of one of the most prestigious universities in India, the Ashoka University. The person is Mr. Pramath Raj. He was also the founding dean of Indian School of Business of Hyderabad, by the way. And in one of the conversation, he said that, Vivek, if education as a field inspires you, then you should focus on education of girls. Because it is said that, okay, I made a statement that because I got educated, I got pulled from a certain segment of society to other segment. Mr. Pramath said that if you educate a girl child, you not only just put one, or let's say pull up one individual, but you pull up one entire family. And that quote that, just stuck in my mind. And I think the inspiration of going after nursing education or medical education somewhat came from here if I look back. Of course, then a lot of things happened. I was fortunate enough to come across a lot of good mentors in that journey. But I think the genesis of the idea came from there.
Thank you so much. And now I'll request Dr. CS Hiremat to, welcome Dr. Uma with a question.
Yeah, as Dr. Karthik Ramesh mentioned about Uma Nambiar, we have met quite a number of times, and her interest to see that how she can build in leadership. That's what she is at, and building up institutions, not only leadership, but she builds up institutions. So, Madam, my question to you is, as a CEO of currently running Parth Sathya Hospital at University of Science, what would be your sort of message to the critical care cardiac nursing team, sisters who are sitting here, how they can shoulder more responsibilities, how they can make a difference to the society? Because a good nurse is always 100 times better than the new cardiac MCH doctor. That's what I look at. And what I learned from my nursing, from my basic training when I was doing my MCH about 30 years back, my sleep in the ICU was dependent on who is the nurse. Instead of just taking a handover of the patients, I should take a handover of who are the nurses on duty. That would decide my 2 hours sleep in the ICU. Because as a doctor, my teachers are here, Dr. Prasanna Simha and my great grand teacher, Dr. Anil Tendulkar, is here. Sleeping in the ICU it costs somebody's life.
So for us to be alert always, this is how I used to look at. So you being a mentor for the last so many years, being a neurosurgeon, which also is a part of the intensive care, what you would like to tell our sisters over here, because that's a take-home sort of a message where they can themselves be much more sort of more competent, I would put it as, or much more ownership of the ICU. That's where we need to create leaders in our country. I want your thoughts on this.
Thank you. Thank you, Dr. Hiremat. And first of all, thank you for, calling me here and giving me this opportunity to interact with all of you. Like you said, rightfully, Dr. Hiremat, most of the surgeons, and I can certainly tell about myself, most of my first surgeries at many times actually have been taught to me by the nurses, not by my senior surgeons as much. Telling me, like when I was assisting, the professor would ask you to open the brain or do the craniotomy, and he would not tell you how to do, and you just read the book and come. It's the nurse who literally holds your hand. So there are, I think, many surgeons are actually have been created in the practical sense by the OT nurses, and I'm sure there are many surgeons who will vouch for that. So I have great respect for that. But as a nursing profession, because I don't see many nurses in senior leadership positions, which to me, it has always been very hurtful in a sense, because you understand more about the hospital. Most patient care, 80 to 90% of patient care is all done by nurses. There is absolutely no doubt about it. There's very little which the doctors do. Yes, they guide, they do, but nurses take the full responsibility of the patient. And if we don't have a good nurse really feeling for the patient and taking full responsibility, we can't run successful hospitals. So what hurts me to see is that in this country, there is sort of a class divide. The doctors, nurses, and administrators. And we don't allow nurses the opportunity to take senior leadership positions. I have, of course, since whenever I have taken over the CEO positions, I have allowed from my nurses, many of them to train and become CEOs and CEOs of hospitals, because I feel they are better suited than most doctors are to run a hospital. That's my personal belief, and I am not wronged in that. And this is an opportunity that I like to give to every nurse that works with me, and I create these secondary career opportunities for nurses. Because one of the things we all need in our lives, and it includes all professions, is that whatever is our basic profession, it takes us to a certain level. And beyond that, we look for certain other value adds in our life. And that value addition, the opportunity for that value addition, is something that I like to provide as an organization and like to provide. And I feel that a lot of nurses who have not thought of it, because in your training also it has not been inculcated. It doesn't get inculcated in our training as well in the medical profession. And I think all of us need to see where we can add value to our lives so that that can be translated into the value to wherever we are working, and the people that get impacted by when we become senior enough and we have responsible positions. So I really encourage all the nurses to think beyond nursing after a certain point in your life, because what you have learned is to deal with lives and have that responsibility. So you have it in you. So just to take it to the outside world as well.
Thank you. Thank you, Dr. Uma. Thank you, Dr. Hiremat. Very inspiring. Now I'll move to Dr. Adil, Mohammad Adil, who's on the screen. Thank you, Dr. Adil. You're just back from biologics event. For you to come in such short notice. Little trivia about him, one line. He's the great grandson or grandson of McReeser, right? After whom McReeser.
Inayatullah Mekri. Yeah, Inayatullah Mekri. So who got the medical fraternity into Karnataka, basically.
Yeah, I'm sure you took a lot of inspiration from your grandfather, what he did, and we really salute what he's done for the state. Wanted to ask you, Dr. Adil, you are at the forefront of innovation in Bangalore Bioinnovation. The theme of this panel is the role of AI in pedagogy and training. I know in Bangalore Bioinnovation, when you talk about AI, I specifically want to talk about augmented virtual reality. training, simulation based. So what do you think is the role of, AR, VR and AI for enabling nurses with, better access to training, better access to, nursing education? Thank you.
So first of all, I would like to thank our Sadhguru for having me here and Dr. C.S. Hiramat. The first thing is that I would like to answer your question in three parts. The first part is that the nurses are being put into everyday job, where most of the nurses are the one who knows what is the requirement for a doctor as well as a patient. And the nurses make new products which are kind of curative. So most importantly, so curative as if like, for example, they need tools when there is a cardiac surgery or ortho surgery or any kind of an alternative thing. So they need specific tools for their daily work, and they make their own tools sometimes. So in my previous roles into various hospital-based incubators, so I have made the nurses to come with ideologies, and now they I would be like prominent to say like two of my trained nurses who have started their own companies and running their own companies, and one company is like I think most of you guys have been buying their products also for their nursing based devices, like medical based devices, which is into this basic surgery based nets, so which is like used in most of the cath labs now. And that company is from Tamil Nadu, and she has gone really big, and now she is making a company across 6 countries of the world. And second thing is, the most important thing is, the nurses don't try to come with an concept of upgrading themselves. They just go into the concept of just upgrading only into the terms of medicals activity. So what is the medical activity? So the concept here is, I am also a clinically trained a person who can do clinical trials till stage 3. So I have been trained in India as well as in Switzerland, in Jamestown. Wherever I have seen, the Indian mindset is that they just wanted to do a basic work. That is, they come to a hospital, they do the work, they leave. But when you go abroad, what they see is doctors are not the first priority for anyone. So any patient who comes, the nurses are the first priority. So nurses try to diagnose the first diseases rather than the doctors come in the second phase. So even in your NHS, you would be having more nurses having the first phase of what do you call that, supporting the patient, so patient care and all this. So where the nurse should understand what they are doing. Now AI based concept, so AI based concept has become really wide, that they should first understand what is AI supporting to a nursing platform. So nursing platform has various sectors of studies. So based on various sectors of studies, they should be in a kind of conclusion that how do I use AI platform? So for example, people should not think it's basically an artificial intelligence. So how do so for example, Chat GPT or your DeepSeek, this is not your general AI. AI is basically a concept how to revolutionize your next phase of work matters here. So how to ease your work matters here, and how to curate this. And at Bangalore Bioscience Center, the from the government of Karnataka, we do have separate ideologies to support this platform, which is the augmented reality as well as virtual reality. So we make people come, especially the medical fraternity come to our center, such that we provide them the basic training, what is to be done and what has to be done and how it has to be done. So for example, if a medical student comes, so we basically give them the AR VR devices. Basically they can even start with their basic injection, and like how do they inject a patient and all these things. And then for example, if a nurse is in cath lab, so we even provide them the concept of how to do a open surgeries and all this, like how do I use my tools and all these things in the surgery. So how do I support the doctors in the surgery. So the concept is, you come with your own concept, we'll make your concept come to reality.
Thank you. Thank you so much, Dr. Adil. So many different perspectives of Gen AI and, using AI beyond Gen AI. Now coming to very important question to Dr. C.S. Hiramat. Sir, I know you from being the secretary of Indian Association of Cardiothoracic Surgeons and also working formally in Sathya Sai hospitals. What do you think is that intrinsic, Harvard Business Review talks about something called as quiddity. So quiddity is that intrinsic motivation of a person, why they do what they do. So it is spelled as Quiddity. What do you think, sir, is the motivation, when a senior surgeon, cardiac surgeon like you, who's operating for so many hours, what is that motivation which you can give to the nurses, to assist, as Dr. Uma was saying, they help you learn, but how do you help them upskill, learn, and how do you keep them motivated to, continue that learning journey, continue to be hands-on in whatever they do?
Now, why we choose this field of cardiac surgery is it's a teamwork. So in a team, there is always one leader. As we always tell, there is always one captain for a ship. So the leader, he is not a leader without his subordinates. So my job, what I always look at, create multiple leaders. As I create multiple cardiac surgeons as a trainer, similarly, we need to train multiple ICU nurses, multiple OT scrub nurses. A cardiac surgeon can operate a case, and earlier during my good old days, my teachers and all, we used to take care of the ICU, but a nurse is required. For example, a drug has to be loaded. I used to load, and my teacher is sitting here, Dr. Prasanna Chimma. He was very clear, I remember during my initial days of my MCS training, Hiremat, you are not supposed to load a drug. It's not your job. It's the job of a nurse, and she does it perfectly. And that's where it is. If by mistake another drug which is loaded, it costs the life of a patient. So this doesn't come overnight. Our senior sisters are there, and we need to generate many more leaders. And the country, entire world require nurses. Very good trained nurses. They just fly across. They are all abroad. In fact, a number of nurses whom I have trained, hardly they are there with us. They keep going abroad because the demand is so much across the globe. So who is going to serve the country? Our job is to keep training. Once I had asked this question to Sadhguru also. We train so much, but nobody retains back. They go. He tells me that your job is to train. So that is part of that. So that over a period of time, it became a habit. So today, if somebody wants to go, I give 2 certificates of recommendations. That my job is next. So that I have got used to it. So once you get accustomed to that training, then we need to do this. This thought came into my mind because here it's a rural India. Here, hardly we did not have any sort of nursing. We started cardiac surgery from the scratch, and operating babies and all was a big challenge. You operate a child in the OR with a good anesthetist, with a good surgeon, with a good OT scrub nurse. But when it comes to the ICU, if you don't have people to take care, the child is dead. So finally, it comes only one person be answered. Even good happens, people take the credit, especially when bad happens. I think we all surgeons face it is who is the surgeon operated. So finally, no fault of yours, you end up losing the cases by a number of reasons. So that easy pickup. Today in this center, we have only one cardiac ICU trainer, Dr. Usha Shetty is here. I don't know if she's in the audience. Yes, she's here. So she helps me to take the lead in the ICU. For simple example, even yesterday I told, on the 45th birthday of Sadhguru Madhusudan Sai, we ended up doing 45 cases with the UK team in the matter of 1 week. It's not that only me and he operate. No, a team was there, but for that leadership, she ended up training 45 nurses who had just done BSc nursing of general nursing. Nobody has cardiac nursing. Cardiac nursing is a separate specialty by itself, which requires extensive training and taking care. So that can happen from generation to generation, so that we can produce our own team members, because the number of people who are suffering from cardiac diseases, number of children born with cardiac diseases rapidly increasing in our country. So for that, we need to be self-sufficient. So after wasting so much of, not wasting, after spending so much of resources, totally free of cost for the patients in this institute, I think if we don't have adequate nursing care, then the purpose is not served. Even though we have a nursing college, we have our nursing principals and teachers sitting here with us, even their hands are tied, because it's a challenge by itself to come to that level. So it's a BSc, MSc, and separate courses we are planning. In fact, I'm sitting and writing down syllabus, how we can have a separate syllabus for cardiac intensive nursing care. The UK team also has joined hands with us. We look forward to come out with a separate syllabus also slowly on this separate specialty. And that's what keeps me driving to see that we train. And this is one of first of its kind of conference conducted. And my teachers are giving me a number of ideas. What kind of panel discussions we have, what kind of workshops we have. In fact, immediately after this, we have our pediatricians and trained nurses to conduct exclusive workshop of 90 minutes on basic life support of a neonate. Today, when interesting question was asked by one of the sisters from Pondicherry, when the chest is open, how do you do a cardiac massage if there's arrest? That's a very interesting question where many people do not know. The chest is closed, and that's where this conference opens up. And we have from the Karnataka Nursing Council, we have an observer sitting us. The Karnataka Nursing Council team was so happy to endorse this program, by the way. And they have endorsed this program. They have sent their observers. And this is how we started off. In fact, they told us that this is the first of its kind being conducted in the country. We thank for taking such an initiative. And for the audience who had come down today, madam, we have crossed 526 registrations. I could not call everybody here physically because of my constraints, but many are there online. That's a big rush. And people have come across the country. So unless we make a difference, somebody has to take an initiative. So unless we make a difference, across the country are there, whether it is South India, North India, East and West of India, Central India, they are here today sitting and actively participating. So that gives us a drive, and I have separate sessions. Each sessions have kept a feedback form, wherein once they give the feedback, this is the first international nursing conference which I'm conducting. It will go on. Somewhere a step is taken, and I think with all your feedbacks, and you go and tell your team members, so that today you have attended, next time you can send your juniors. Keep that mind open, and that's how we can make a difference to the society, sir.
Thank you, Dr. Hiramat. I think the last few minutes, I just want to make some observation. So the theme was, intentionally, usually in many IICTS conference, Dr. Hiramat asked me to talk about AI. But today, Harvard Business Review says AI is authentic augmented intelligence. It's not artificial intelligence. We think AI is a new skill. It's a new science. It's not going to replace. And I want to give in like 60 seconds, very quick anecdotes, because Dr. Hiramat was asking me to share. Already, Dr. Adil has shared a lot of insights on how non-generative AI models can be built. And I'm sure, we'll hear a few words from Vivek also on the platform, how you have AI powered it, right? But as I said, you cannot replace the role of a nurse, or you cannot replace skilling with just, a chatbot, a virtual assistant. Today, AI is used for creating personalized pathways of learning. We have companies in Australia and UAE. So I work for the Royal Family Office there. So we have invested in companies. We see a lot of nurses who are coming in from India, especially also Vivek was telling me to Europe, UK. So in upskilling, in reskilling, there's a lot of role of AI to do this. But can AI really replace? So I want to give you two quick anecdotes before I ask a final few questions to Vivek. When my mother was recently operated for a knee surgery, so I was telling her I'll put an AI-enabled camera in her room because she should not walk for some time and she needed additional carekeeping. So she said, can you just get me a proper nurse, a human nurse? I don't want an AI-enabled camera which will detect motion. No, I said there are geriatric-enabled cameras which will know whether you're flat or you're vertical, if you're fallen. These kind of cameras are available. She said, I don't want any of that. I want two human eyes to be watching me all the time, right? So this trust factor is there. During COVID, I mentored several hackathons across the world. And I got an opportunity to work over, 20,000 developers in different countries. So hackathon is where we solve problems. Many of them came up with the role of robots, autonomous robots, as I said, virtual assistants and assisted, navigation bots. So in China, especially where COVID started in Wuhan, in many hospitals, you would see these robots going and giving food, right? In India, we did this experiment in one of the hospitals. In fact, we launched a male robot. But the response of the hospital patients was that we want a female robot, right? So more power strip.
How do we classify male and female robot? What are the technology involved in that?
So we just put eyelashes on the robot. We put literally we did this. We changed the branding to be more diversity, pink, and because that subtle factor you're talking about emotional quotient, or even for a robot, people don't feel comfortable. They don't want to see a huge masculine robot in a hospital, or they don't want to see something which looks like a tray. It's the opposite effect, right? So now quickly, last 2-3 questions, Dr. Hiramat, we started late, so give us another 5 minutes because I think we have some experts here. Vivek, asking, tell us, I know it is built in-house. What do you see the role of AI? I know you're using a lot of cloud hyperscaler AWS services. Is AI really a real thing for nursing education? Because you are in that field. Sure. Can you tell us something about it? Yeah.
So it would have been impossible for me to build my company without AI or without technology. I'll tell you why. See, traditionally, how has these centers of education built, be it Nalanda University or Takshila or AIMS or ISC or this. You acquire a 200-acre of land, you build these like mega campuses with residential infrastructure and all. Now that requires humongous effort on the part of humanity to come up with something like this. And it happens once in a generation. Or imagine this institute, the effort that it has taken. The approach that we took instead was that we will open 150 to 200 or 500 smaller centers across the country so that I can reach every pin code of the country or every district. So my business plan in 10 years was to open 500 smaller nursing college and allied health colleges across the country. Now, if I follow that approach, what's the biggest problem to building that business? Where are, let's say each campus would require 5 nurse educators. How do I hire 2,000 nurse educators? The same problem that a hospital faces. How do I hire 2,000 nurse educators who are good at quality training? That pool of candidates just simply doesn't exist. How do I hire that many teaching assistants? So that's where the technology angle started coming into place. AI is not replacing my nurse educator, but AI is dramatically improving my student to nurse educator ratio. A nurse educator, which previously would have been able to handle only 20 students, with the use of technology is handling 200 students. So with the same set, what is a finite resource in the country right now? A trained nurse, right? With the same trained nurse, I am able to produce more candidate. Second, AI is playing the role of teaching assistant. Evaluation, FAQs, doubt solving, problem solving, that's all done on the platform. And even I was surprised about how accurate and how powerful the technology is. Third, content. About 40% of my content is developed by AI. Of course, there are expert trainers to evaluate that content before it goes into publication and before it goes live. But 40% of the legwork is done by AI. Then imagine every campus has a virtual reality lab, which gets built with an investment of 1.2 crore. That's very, very important. Most of the nursing colleges lack that infrastructure, but it's very important because you need to get net practice before you work on an actual patient. You need to get...
Sir, let me interrupt. We are coming up with that nursing reality lab in our institute.
Of course. So leave aside the top 20 percentile nursing colleges in India. Of course, like I said, this is a center of excellence. So, but I'm talking about, imagine a standalone nursing college somewhere in Chhattisgarh. They would not have been able to make that investment, right? So the candidates who are coming out of such standalone colleges would not have ever handled those situations because they would not have seen a real patient and there is no such infrastructure. So what it allows you to do is, it allows you to do some net practice in a risk-free environment. So I would say that AI has completely transformed medical education, not from the perspective of making humans redundant, but from the perspective of making humans infinitely more productive. And it doesn't end pre-qualification level. It doesn't. The role of AI doesn't end till the time you gain your degree. Yesterday, I was talking to a company which runs smart ICUs. The example that he gives, it's a company called Cloud Physician. They manage about 3,000 ICU beds in India and the US. In a traditional setup, one intensivist can only cater to 3 beds. That's the ratio. That company, with the use of AI and of course trained human, are achieving a ratio of 1:80. Now tell me, would it have been possible without AI? Because to manage 3 lakh ICU beds in India, where are the intensivists and where are the trained ICU nurses? They just don't exist. And no matter how many, we still have only 700 medical colleges and about 5,000 nursing colleges in India. The education pipeline is not good enough to support the deficit that we have in terms of ICU nurses. So I think of it from that perspective. AI is never going to replace humans. They are never going to take your job, but AI is going to make you infinitely more productive at your job, and AI is going to help you in delivering a fundamentally better quality of care to your patients.
Thanks. I think Jagannath has something to ask, and Prasanna, yeah.
Yeah.
Dr. Tandulkar, yes, sir, done.
Good morning, all of you. Way back in 1984, when I walked into the state-of-the-art ICU in Railway Hospital, Perambur, it was manned by 1:1 nursing ratio. And the nurses spent almost 90% of the time doing nursing job rather than doing something else, which I will come to later on. Now, today, when I come into the ICU, I find that there are nurse supervisors, there are nursing people, and then there are IRs and so on and so forth. The nurse and the nursing people actually spend probably less than 60% of their time doing actual nursing duty. The remaining is done in filling up forms. Now, does AI have any solution to it? And I request the nurses to come out with problems that you face rather than, keep shut over here.
Yeah, they can find solutions, yes.
I was also going to be telling literally that what nurses, and this is a complaint from the nurses itself, because I have been trying to get what you call DOs or whatever they are to enter data. These are mundane work which a nurse should not really be doing. Her job is to tender loving care, which she is unable to give. I want my nurse to be with the patient, but unfortunately we find a lot of mundane, and I'm sorry to say, but all those NABH and all those things are only increasing the paperwork. You may, as long as you sit and write something, they're happy. The evaluator who comes, and I am not joking, the evaluator who comes in these things are more bothered about the processes than the actual outcome. I'm sorry to say, the ideal may be there, but this is what is happening. And you can see where the nurses are bitter that I have to sit and everyone is more interested in me filling a form than me executing the job. Yes, they have to execute the job and document, but that part is being, my nurses are literally 89. And another thing, like you said, is we need to have, for example, alarm fatigue. My ICU alarms are just going beep, 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 beep. I think every nurse, and then what has happened is that this thing. So even if AI could reduce the alarm fatigue and help direct and draw this thing, we talk of mews, pews, and other things. Actual sentinel events are not picked up, but the alarm is literally the alarm is being shut off. So that because the sensitivity and the specificity of that alarm is so useless, it loses its thing. In fact, it becomes dangerous. I give you another example where I could think today. I just went into the ICU there. We needed to get the dose of a drug. Now, if a voice, for example, a voice command could go to the formulary to give the exact amount of drug. I mean, we traditionally say, I just gave my PDF of the drug formulary. And so many of these things which go up, down, and waste a huge amount of time in this thing, if they could be accessed, I think he made this thing so that when the drug is going to be loaded, for example, the discussion picks up. Even I don't know whether it's possible or not, but then when, let us say there's a thing going wrong, if they could integrate all the amount of data which we have to help us go towards just like you go around using Grok or whatever and try to find the answer, and then we get a review of a human, it would reduce the amount of work, and they should be and they can be doing nursing rather than doing everything else than what they're doing.
Thank you, Dr. Prasanna Suma and Dr. Jagan. I think very valid, pertinent points. And this is more of use of robotic process automation to, you have addressed a point of nursing fatigue. And I want to quickly make a one-line comment here that we'll take your input seriously. Last year in Muddenahalli, we launched at this time Healthcare Hackathon of India, where we tried to solve problems. This year, Dr. Hideman, let us introduce the nursing problems into the hackathon.
Yes.
Let us use technology to solve the nursing problems. I think Dr. Uma wants to make a few comments. We want to hear from you. Yeah.
So, taking from what your input has been, the one is that we need to change our mindset. Documentation is very important. So anybody who thinks that what I'm doing, I just can do and I don't need to document it is wrong. So please understand that documentation is important. What today digital technology does is to help you do smart documentation. It reduces the workload from writing on paper and then when you need it, not being able to recognize it, from having a continuous medical record available to you for reference at any time. We talk of AI. Now, if a smart AI algorithm has to be built to help you in your job, you need the right data from the field for that. the data that has been entered at the time of executing the task. And that is our responsibility as healthcare providers on the field. So no AI can help us. We cannot build anything unless we have data on the field. So one of the biggest problems that we have in India today is the resistance to document and resistance to use EMRs in the manner that they have to be used, because we think it is, why should I be doing it? And a lot of us, doctors, nurses, technicians in hospitals, do not fill our EMRs because we think that nobody sees it, nobody needs it. So let's, okay, my job is done and I'm going. So I review a lot of EMR documentation when I go for audits of the hospital. Lot of people just put dots and stars, which includes doctors. In the place of diagnosis, when I go and see what is the diagnosis on most patients, 60% of data in a hospital, which is a very big private chain of hospitals, had only stars and dots and dashes because it's easy to just do this and go away. Please don't do it. My request to all of you today is to start entering data. It takes a little time in the beginning, okay? And maybe some of you are not using that advanced technology of documenting. Now, data acquisition tools today are no longer just, you don't have to type. It has gone to speech to text, it has gone to ambient listening and speech to text, understanding your accents without having extra training to be done by the software. All that is available today. If you start at some level, you will reach these. So please, with whatever is available to you, start documenting it. And please document 100% of the data as you are doing your procedures. So you talked about drugs, dosage and all that. We have smart infusion pump integrated with drug databases that the moment you, whatever drug you want, when you indicate the specific parameters of the patient, it calculates the drug dosages and starts. I mean, BD, Baxter, Bebron, all of them are bringing all of that stuff today in the market. So this will become commonplace if we start to use it. Now, today it looks like it is very expensive. Yes, it is expensive. It's expensive because only 1 or 2 hospitals buy it. But if 1,000 hospitals were to start buying the technology, it will become cheap. And it will become easy for all of us to use it. So I'm not advocating one technology. I'm saying it is our role to work to make our lives easier and to make our patients' lives safer by using technology. And that is the only way we can also then help build better AI algorithms to help us in our work.
I think Dr. Adil wants to add some. Thank you, Dr. Uma, for valuable inputs. Dr. Adil. Yeah.
So, as Dr. Uma had mentioned, nurses are the heart of healthcare, the first important thing. So, they are there day and night, on weekends, holidays, everything is there. But the most important thing is they need to have their outcomes. So, if they don't have a outcome properly, which is literatively or figuratively, so they cannot save lives. So, people say doctors are the one who is saving life. It's not that doctors. However, the heart of healthcare is facing a crisis, most importantly. The reason is that the nurses don't understand where the documentation has to be done. The first important is they need to understand what is the medical technologies they are documenting, what is the treatment options they are documenting, and what is the pharmaceuticals they are documenting, and how are they intersecting with the concept. So that is the most important thing if you want to give a quality care. Now everyone speaks of the quality care. That is kind of an all-time high, the most important thing. And everyone goes for the training, upskilling, and all these things. But when you cannot give a proper data based on what is the enhancing the patient care through upskilling, or maybe based on retaining the staffing of nurses, or maybe like how do you manage the timing. So you mentioned about what do you call that, the alarm systems and all these things. So you don't understand what is the problems you are facing, because your problems are the data. So you need to make sure your data is there for any kind of AI tool to be augmented. So most importantly, if you don't have data to be encrypted in the technologies these days, you will not be entitled for the next phase of life. So, for example, whatever the work you are being doing in the point A, the second day also you'll be doing the same work. And that is why what we do is, for especially the women-based entrepreneurs, and if they are from the medical fraternity, we give them 20 lakhs directly to make sure they come with an idea that could be becoming a proof of concept, such that this proof of concept could be a startup or maybe a solution to support the medical fraternity.
Thank you, Dr. Adil. So I wanted to ask that last one word. You are committing that any of these students here, nurses, or any of the medical, if they come with an idea, you'll give them 20 lakhs.
Yes, exactly.
See, that's a very good option for all of you now to come up with innovative ideas. How you can reduce your writing?
I know
You
Dr.
can come up with
has
ideas.
a question.
So I have an offer to.
I wanted to ask you, what is IIC medical?
No. Right now, to what Adil has said, if any of you comes up with a program to train your colleagues in nursing informatics, Adil will give you the money and he will give you the platform.
Training.
That is what we will do for you, but it has to come from you.
Yeah, Dr. Tendulkar, please, sir.
Yes, sir.
Tendulkar.
Yes.
First of all, I agree with my both colleagues, what they have said about writing. Number two, I want one comment and one question to Uma Nambiar. Comment on Karthik. My wife was in extremely critical state during COVID. She was on deathbed. And thanks to this technology, a video link was established and she said, bye-bye, I'm being intubated and I'm going to die. Fortunately, she survived. First thing she told me, what she required in ICU was human touch. Because everybody was in that COVID dress. And first time you realize that what you speak, you hear from eyes, not from ears. It is like speaking to a wall and you think that wall is talking to you. No. Finally, you require a human touch. So as I agree, as he rightly said, it is not replacing human, it is augmenting. I like that concept. Thank you very much. So she today remembers that she wanted a human touch, a shoulder to cry, somebody to empathize, somebody to express. So if your robo come to that level, perhaps, and she may ask for perhaps a man robo rather than a female young handsome man robo. I like the suggestion by Uma Nambiar, Dr. Uma Nambiar, sorry. That,
because I worked with you in.
So Dr. Uma has worked with you.
She
40 years back.
So whenever somebody says like that, I'm little scared whether she has got good memories or not. And she was in Navy. So, anything mistake is.
She said excellent memories. She said excellent memories.
Thank you. So, no. My wife is an anesthetist and she strongly believes that anesthetists will be the best CEO of a hospital.
Wow.
Because they are physicians, they know the physician part, they know the surgeons, they interact with nurses, so they are the best. So I like your suggestion that nurses will be the best, one of the best hospital administrators. I want to ask you to achieve the skill as an hospital administrator. What today's nurses, their basic training should be. Because their basic training today is medical, and medical.
Even for doctors.
Same thing.
No, for anybody, I think for all individuals, all
Nurses.
professionals.
Now let us know, this is a nursing conference.
Right.
Looking at their, all of you are 12th standard or BSc?
Yeah.
BSc. So 12th standard, then they are opted for 3-year BSc nursing, 4-year BSc nursing. Sorry. Forget the years. What I mean, forget the years part, but what fundamental education they should undergo training. Because I'm sure after your suggestion, at least 1% of the crowd over here will opt for a different type of job. So what do you think their training should include?
So mostly, once we are in our mid-career in our chosen profession, I think it is time to then start looking at various other leadership options. And you see, what are the other options? Now, let's say we want to be in the healthcare industry. Aisa to hai nahi ki somebody is going to take us into a hotel industry and make CEO. Nahi hota. Okay, so there are multiple other courses that are available. Start investing in your own self. Now, one of the mistakes that we make is that we think if somebody will pay for it, we will do a course. Don't wait for that. Invest in your own development and keep reinventing yourself. So look for options, courses in leaderships, courses in management, courses in finance, healthcare quality, healthcare administration. There are multiple courses available. Start with 1 year, 2 year, 3 year, on the job training, take leave and do training. The option is left to you. And let me tell you, I mean, I did a mid-career MBA. People said, why as a neurosurgeon, why do you want to do an MBA? I just wanted to do something different. Each time you do something different, it does not mean that it has to end up in a career, which is a different career. Each course that you do teaches you something and improves you. So for our own self-improvement, you start doing it. But it is at mid-career that you start thinking at what other thing you want to do, because you have by then gained good expertise in your chosen profession, which is extremely important. You have to be very good at what you do, and you have sufficient maturity to understand how your personality and your skill fits in with the rest of the world. Because that's how you understand. Once you arrive at that maturity level, and then you choose to do something else. And I have friends in India, nurses, who are CEOs and COOs. Okay. And all three of them are extremely good friends of mine. And I usually call them into my hospital to teach nurses what is it beyond nursing that they could do. Because nursing is not be all and end all for everyone. For some it is, for some it is not. So we have to start looking at ourselves as leaders. Like somebody always says that always try and act like your boss, so that you can be the boss and leave your place for somebody else. So do that.
Wonderful, Dr. Ma. So the best way to judge a session is when you stop looking at the watch and you overrun the time.
We have overrun the time.
We have broken all the records of all the sessions. So I know Dr. Adil wants to say something. If you could keep it very brief, sir. I know you're joining from Goa, so please.
So
Just one minute,
thing
sir.
is, in Bangalore Prevention Center, we do something called skilling of nurses as well as the allied health science students. So it is mostly the PG people we do take for these programs, which we make them as intrapreneurs as well as the entrepreneurs. So once they have this, what do you call it, medical degrees and diplomas completed, so we make sure we take them for a 6 months period or 1 year period. And based on, there's some few fellowship also from government of Karnataka. So where we make sure they understand the mechanics of complete management of how do they do their intrapreneurship or their entrepreneurship. And for especially now, if someone is having a idea, so there is some program called We Escalate by government of Karnataka. So where we'll be taking you for 6 months period. So where we'll be training you completely, fully funded by government of Karnataka. So just 9 days is pending. So if you want to join, they can join completely.
Yeah. That's
Two offers made by Dr. Adil, so please maximize it. Dr. Hiriman, please. Yeah.
I think, Dr. Sivanand, who is the principal of our nursing college. Yeah.
Yeah,
Brief,
as Madam has told, actually, one of my student has done his MBA and he was now working in a multinational company as an administrator. It's very few people have diversify from nursing to the other field, and there are one more person is there. He is doing in software engineer. Software he has gone not an engineer, but later he became team leader and is earning almost 1,26,000 per month, even right now. Addition to that, I'm so happy that Dr. Sir has explained nurses are doing most of the clerical job in the ward. It's 100% is even in ICUs or general wards, most of the nurses are bothered about recording and other things. That clerical job, it's more, I think that's why in our hospital also we plan to have a computer assistant for each ward. We had planned, but actually it failed because 2 or 3 nurses are working together. Coordinating with them, it's very difficult. The number of nurses in clinical area is also decreasing nowadays. Probably it is not attracting more number of people to the profession. All these things plays a predominant role in our nursing.
Yeah, thank you. Any questions from the audience? Nurses, anybody has any questions?
You will not get a panel like this, so many eminent people. So please.
Yeah, yeah. Shanti, only not for Tendulkar. You should ask other questions also. Mic to her, please. Mic. No, the audience can't hear. The world can't hear. By the way, this is going global for your kind information. Oh. The hall can hear, but who are there online audio, they can't hear. Yeah, please go ahead.
Sir, can we
Close to your mouth.
all the data like all hemodynamic monitoring and ABG values in the Google Sheet, and anytime you can view like all the nursing what do you call whatever we find in the patient. If you record everything in the Google Sheet, anytime we can like that. Can you make any app like anything, sir?
If it grabs real time,
Yeah.
Simplify the format.
Anyway,
Yeah.
sir, like Google Sheet, if we share to our consultant or anybody can, they need not to ask every time what is the output, what is the BP, like.
So directly don't want the surgeon to disturb you more frequently.
No, sir. When the pericardial drain was removed, when the ICD was removed, if we record all the data.
There are sensor-based AI apps today which can directly give the information. Sir, you wanted to say something? Yeah.
She is not able to put the problem exactly what is required. What is required is that you reduce the amount of manual data entry, increase the amount of data acquisition directly digitally. Now you could use, cameras to which they can point the drug. So the drug is identified, and then they can voice over saying that patient weight, name, age, this is the dosage that I require to give. The output comes directly. I mean, this is a kind of platform which I think we need to do.
Yeah, process automation.
Use of documentation is what is required.
So just we are out of time, but one quick word.
I'm not a clinician. Dr. Uma will throw more light on it, but this is a session on AI, and there's a lot of emotion around data entry. So I'll make a broader point. See, the requirement of documentation is only going to go up. Some of you would be, let's say, looking at going to, let's say, higher wages market like UK or US. Let me tell you the amount of documentation that you have to do as a USR and as an NCLEX qualified nurse is 10x higher than what you do in India. It will also go up as the payer profile changes. Right now, it's out of pocket expense. Your patient is paying on his or her own. 60% of that is for private hospital data. As it changes in the favor of insurance, the requirement is only going to go up. But I'll also tell you a positive aspect. The rate at which technology is growing so fast, and see, AI is actually supposed to take away these jobs from you. AI is never going to take away the job of a person who thought of organizing this conference. AI is never going to take a knowledge worker's job. AI can never take the job of a person who thought about building this great institution.
Thank you.
And AI is never going to take away your job, the job of a skilled person, right? Because let's be honest, how many of us will be comfortable a robot coming and putting a cannula on our hand? At least I won't be for next 20 years. But AI will take away these mundane jobs, which is bothering you right now. Today, what's happening is even the hospital information systems are 50. Every hospital follows their own HIS. The electronic health records are also, it's not one common platform, but the rate at which technology is growing, I think we are not even decades, only 3 or 5 years away when whatever you are saying, the pain that you are feeling in terms of, let's say, putting too much of data will greatly get streamlined.
Thank you, Vivek. Yeah, last words from Uma and we'll conclude. Yeah.
Yeah, and today we have the possibilities, from your ventilators, monitors, directly the data gets acquired into the EMR. You just have to see it. And the drug, whatever is written, it also calculates the dose and then it suggests to you, then modify it according to what you want, and then it also remains. So you have to do very minimal in terms of writing. It is more about checking what the computer is, what your EMR is suggesting to you. And because of something called interoperability, which means all the different softwares that are operating in your environment, they speak to each other. So each machine speaks to your software, so that way there is an end-to-end seamless patient care, which can be completely digitized with very minimal input from you. The input that is required from you is the intelligent, knowledgeable input of saying, what has been suggested by the EMR is correct for me. That is available today. As I said, it's a question of how much we are willing to pay for it today. That is where it is. But over a period of time, that will also get leveled out.
Thank you so much, Dr. Uma, and thank you, Dr. Uma, for coming all the way. Vivek, it's quite a drive to reach Muddenahalli and all the senior doctors here. I will take 20 seconds to offer my, in Japanese, they say, arigato gozaimasu. So this is your heartfelt gratitude to Sadhguru Madhusudan Sai. I have to tell all of you nurses and or doctors, professionals, 2 weeks back, he was in Chennai with us, visiting IIT Madras. 1 month back, he was with us in Indian Institute of Science. He's constantly looking at, while we provide, as Dr. Tendulkar said, human-based care, human touch-led care. He's constantly looking to push the envelope in terms of how more of these technologies can make the lives of all medical professionals easier. And 2 last comments I want to make in 10 seconds. Boston Consulting Group talks about a word called bionic, right? Where it is human-led, human-enabled, human touch digital transformation. And it is all of you nurses and all professionals are going to do that. And I want to thank all of you again. I think all of the nurses here, at least from the panelists, deserve a standing ovation for, what of the wonderful work which all of you are doing. This is for you from us. You please sit down. But you can applaud for yourself. Thank you so much. And I want to thank Dr. C.S. Hiremath, sir. I think this has been the best panel discussion. Thank you for coming up with this concept. Yeah. Thank you for getting a stellar group of panelists. And thank you for making such a hugely successful conference. Thank you, sir.
Thanks. By the way, Dr. Uma Nambiar is one of the NABA inspectors. And he is the AI advisor for the King of Abu Dhabi. He has come from Abu Dhabi today. Thanks.
Thank you, Dr. Adil. Thank you for joining.
Thank you, panelists. So moving on, basic life support training is mandatory in all healthcare settings. So we now move on to hands-on training session for basic life support. The instructors are the senior in charges of PICU, NICU, Cath Lab, and CTVS ICU team led by Dr. Harsha, the head of pediatrics and pediatric intensive care at SMS IMSR.
As they set up the tables, feedback QR code, can you put it on display, please? Scan the QR code. You need to fill it.
Also, the nurses who have not registered yet, please, we request you to register. It is mandatory to get your certificates.
Without filling the feedback QR code, the form, if you don't fill, certificates will not come to you. The moment you feed it, we will be sending it the feedback form.
This is mandatory for both online as well as offline delegates.
Kindly scan this. We have created a form based on each session. Wi-Fi? You want Wi-Fi here? Oh, Wi-Fi. Our IT manager is here. He'll tell you. He will display it right now. The table is ready. He will display the Wi-Fi password here. You can download the Wi-Fi password and scan. As a setup, we have Dr. Harsha with us. He is the head of department of pediatrics, and we have Dr. Choi. There are certainly, you can take a photo of this. So while going, you scan and then fill the feedback form. Take a photo of this. And we have Dr. Joy. Dr. Joy. Dr. Simran, please come. Please come on the right.
I will move it.
In this, as I mentioned, how we are running with a single ICU nurse and training others. Well, if I mention our OT scrub nurse who works with me from morning 4 a.m. till 12, where is she? Tejaswini is here. She is there. A big round of applause for my OT scrub nurse. There are only two. Remaining are there, but these are the ones whom you can operate and keep going on.
Hello. Hello.
Follow my case. Over to Dr. Harsha, please. He has some presentations and then subsequently he'll take it forward.
You can present. Yeah. BLS. Change it. Change it. Right. Okay. I'm going.
Submit only. Submit.
So I'm going to start this session. You can continue with this later. So next slide, please. So there are two things here when it comes to BLS. One is out of the hospital and one is inside the hospital. So inside the hospital, one thing is early recognition and prevention. Early recognition is like what you have, news, pews, news, those are the things. Next is activation of emergency response, high quality CPR, advanced resuscitation, post cardiac arrest and recovery. Next slide. So what is important in children? Most important cause of arrest is hypoxia. So we have to give importance to ventilation. Next slide, please. So what are the situations you are ever? Someone has collapsed in front of you, or child has collapsed, but you don't know when, or a lay person is doing a CPR. These are the situations you go. Next slide. So what is the first step? First step is verify scene safety. That means the first figure, you don't have enough space to resuscitate. A live wire is there, accident zone or fire or electrocution live wire is there. So you have to first safety, ensure scene safety. You have to speak loud, telling that the scene is safe. Next, so you have to protect yourself, bystanders and others. So if it's in center of traffic, try to take it to the pavement. So scene safety is the first. Next is what is different from adult. Adult most common is cardiac arrest, where you are giving importance to a shockable rhythm. So they're getting an AED. So you give activating code and getting AED is important. Here, single rescuer is there. Ventilation is important. Check for responsiveness, shout for help. If you feel appropriate, activate if you are single. But when you are two rescuers, the one rescuer will attend this one, the other rescuer will activate the code and bring this one. Next. So what is important when you are activating a code or when you are calling? So many times it happens like NABH and all, activate a code blue, code blue, code blue. Which word, where, it's not known. So first identify I am so and so from this word. Are you able to hear me? That means sometimes you might not be able to hear. Even in you are using a hospital system or outside. Identify the location, number of victims, age of the victims, and how many rescuers you need. So when you go into the chart, there are two things. Initially activating called emergency medical response and emergency medical services. You get confused. Emergency medical response is any person who is trained to do BLS. Emergency medical services is when a trained person is needed. So that is there. So after asking them, ask them to repeat what you said so that they have understood. Then only hang the phone. Otherwise, just telling and keeping the phone doesn't give you proper response. Next. So how do you act? First is, once scene is safe, checking for response. If it's a child, you can just, hello, are you awake? You can tap the shoulders like in adults. But if it's a child, you tap the foot. So if the child is unconscious, someone you want to have help, you can call them. Next. So you are checking for the response. At least you have to check for 5 seconds, not beyond 10 seconds. So, okay, where do you check for pulse in an infant? Inner side of the arm with the 2 fingers. Or if it is a child, you can either check the carotid on the same side, not on the opposite side. You will be pressing on the carotid tubercle, that will further deteriorate the condition. It will activate the carotid reflex. Okay. Or if it's a child, you can also feel the inner side of the femur. So how do you feel? So as soon as you feel 1001, 1002, 1003, 1004, 1005. Same time, pulse is felt and is there respiration. Next. So if what are the situations? There is a normal breathing and pulse is felt, or there is no normal breathing, pulse is felt, no pulse and no breathing. Next. If there is normal breathing and pulse is felt, you keep monitoring and keep reviewing every 2 minutes till the emergency arrives. Next. If there is no normal pulse or breathing, so or a gasping respiration, but pulse is felt, what is the first thing you have to give? Rescue breathing. Every breath, every 2 to 3 seconds, a tilt chin lift, all should come instantly. So squeeze, relax, squeeze. So every 2 to 3 seconds or 20 to 30. But important here is the pulse can decrease anytime. So if it is dropping below 60 anytime, you have to start a CPR. Next. So this is for single rescue. So you give a cycle 30:2. Because you are a single rescuer, if by this time you are given a 30:2 cycle of CPR and you are not yet activated a code, please call for a help and activate a code, get the AID. So as soon as the second helper arrives, give 15:2. You have to give more importance to ventilation and attach the AID as soon as it's available. Next. So it says after 2 minutes of CPR, if you are not able to, if you are not yet activated the code, please activate the code. Next. So the same. Next. How to activate the code? So 2 or more rescuers are there. Till the other rescuer brings the AID, 30:2. As soon as he comes with the AID and attaches the pads, you have to go for 15:2 respiration. Next. So once AID is there, attach. Remember, while attaching AID, you should not stop chest compression, except maybe if 2 big pads are there, you have to attach 1 pad at the back. That is the only time, but limit to as less than 5 seconds. So if it tells shock, give the shock. But while analyzing rhythm, don't touch. While giving shock, no one should be touching the patients. So immediately after delivering the shock, you should resume CPR. Next. So this is the cycle, single or double rescuer. I have made a checklist so that after this you can practice. Any doubts you have, you can ask that. Next. So what are the proper respiratory rates and this all. You can see adult, you bring AED first. In a witnessed collapse, so follow the steps of adults and adolescents, that is activating the code. Unwitnessed collapse, you give 2 minutes of CPR, then activate the code. So how much you compress? 1/3, at least 4 centimeters in infants and 5 centimeters in the child and adult or adolescents. So where do you, I'll come to where to each steps later on. Next. So ideally is 2 members at least should be there. Ideally 2 persons should be there for airway management, because securing a mask is an important thing. Okay, so it's ideal 2 persons are there for a bag and mask ventilation. If it's not there, you can continue. What single rescuer is using, you can use face mask or a face shield. Next. So what does BLS define? Child from 1 year till the age of puberty, infant up to 1 year, neonate up to 28 years of age. So rates of compression is 30:2 in single rescuer, 15:2 when 2 rescuers are there. So more. Next. Previously. So in an infant, if you are alone, use 2 technique. So just below the level of nipple, you have to 1, 2, 3, 4, 5. So 30:2 when you are alone. So when 2 rescuers are there, it is better to wrap your fingers around the chest and lower of the chest and give compressions. So make sure that you don't bend your thumb. Many times injury occurs due to your nails. Next. So when you are giving compression, there are 2 things. One is AHA, just below the level of nipple. Whatever it is lower part of the chest. Or Indian Association of Anesthesia, it tells 2 fingers above the tip of the xiphoid process. Everything is safe. You are putting it at the lower end of the chest. So what is important is your fulcrum, that is your hands remain straight. So this is an adult. So you don't need much force. See, if I'm vertical, it's my hand as there. You don't need much force. Your force should come from here, and even one hand is enough to do. So we find difficulty. What is the most important thing is we don't lock it properly. So what is first thing you do is, now lock your knuckles. Once your knuckles are locked, people just keep like this. So your elbow should come front, and you should see to that your hands are vertical. So it comes easily. 1, 2, 3. So every time you can get a release back. It comes automatically if your position is right. If it's not right, this one. So you have various mannequins now, which gives a feedback whether you are doing right in terms of percentages, or even with the Bluetooth on screen, I can set up 10 stations and tell who is doing right and who is not doing good. So that is how AI tells you have to. So this feedback with a proper resuscitation is a requirement slowly coming up. So that means you are learning the skill properly. Next. So alternative technique, or if it's a child, you can use this single hand, because you might end up using too much force with 2 hands, or in adult, you can use the alternate technique. Next. So if you are on a floor, as showed earlier, so you have to kneel down, see to that your hands are straight. Okay, next. So what is rate of compression in infant? 100 to 120. Infant depth is 1/3 for everyone, but it is 4 centimeters for infants. Children is 5 centimeters. Adolescents 5 centimeters. Allow recoil every time. So as soon why you are practicing here, you don't hear in repeatedly, but here I should hear a recall sound when I am compressing. That is how you practice. So minimize interruptions less than 10 seconds anytime. Next. So sometimes you have a airway obstruction, you need to, so secretions will be there, gurgling stones are there, stridor can be seen. So how do you open an airway? Simple. head tilt, chin lift. So same thing. Next. So when you have, if you hyperextend, then also there will be a obstruction. So only you have to obstruct slight extension. That's all. Next. So when you are suspecting a cervical spine injury, what is mostly you are not supposed to do a tilt chin lift. So you have to, if it's a little bit big baby or child or adolescent, you can use your thin air eminence as the chin and lift it vertically. Behind the mandible, lift vertically. If it is a child, you can use your thumb and fingers, or even you can use this, but make sure this one is not pressing on the eyes. That is the most common mistake done every time. Okay, next. Next. So next. So rescue breath. So if the pulse is there, respiration is not there, give rescue breath every 2 to 3 seconds. In adults, it is 1 breath every 6 seconds. Next. So 30:2, single rescuer, 2 rescuers, 15:2. If advanced airway like endotracheal tube is there, you continue giving compression, the person giving bag and mask ventilation will give the compressions every 2 to 3 seconds. Next. So if I'm single rescue or emergency abroad or this one, everyone has something called as pocket mask to give more. So mouth to mouth, mouth to mask, mouth to bag. Next. So this is available commercially, not cost much, from 50 to 200 rupees, or autoclavable masks also are available. Next. So mouth to mask, back to mask. Next. So remember, when you are doing, you have to take a tilt chin lift from chin to bridge of the nose, that is then a tilt chin lift, give breath so that only chest rise, visible chest rise is there. You need not blow too much. Next. So EC clamp, when you are having, a bag and mask, what is important is C. This is the C where you hold here. Don't hold at this time here. Hold here. Then C. C is on the jaw. So head tilt, chin lift, and you give a breath. So what is the point? You have to see a visible chest rise. Okay. Next. Next. So ideal is 2 persons holding. That means 1 person holds the mask, other person gives bag and mask ventilation. Next. So how do you give compression? Give 1 breath or 1001, relax, 1002, or 1001, 1002, 1003. So that is 2. The breaths you give 15:2 and start CPR. At the end of stopping, like you're finishing 2 minutes of CPR, don't end just at compression. Give 2 breaths and then look at the AED. Next. So you have to use a proper size bag and mask. Next. So 1 rescuer is there, better use a barrier device because you'll be wasting holding bag and mask unless you are trying to use it very fast. Otherwise, better 1, 2 rescuers are there, better to use bag and mask. Next. Next. So AED. Why this is important? If you are in a cardiac environment, like few days ago, which I heard from anesthetist here, 1 baby was desaturating and everyone was trying to load adrenaline. When the rhythm was showing, it was shockable. So that is more important. So survival of witness ventricular fibrillation with arrest, 7 to 10% per minute it decreases if no CPR. But further, if you are giving CPR, it reduces to 3 to 4%. So, and 90% of ventricular fibrillation revert to normal if you give within 1 minute. So this is from Indian Association of Anesthesia, which I have taken. Next. So this is an AED. How it works? I just need to Switch on.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light.
So if I attach the pads, someone who is giving compression, I should not. Analyzing heart rhythm, do not touch the patient because your rhythm might be
Stay clear of the patient. Deliver shock now. Press the orange button. Shock delivered. Start CPR.
So importance of AED is it gives you the indications. Analyzing rhythm, don't touch. Giving shock, don't touch. And continue. Immediate step after giving shock is resume CPR. That is most important. You don't look at the monitor. Only after. Yes, sir, it depends. This is a child, this company has given front and back, but you need to separate. You should have a distance between this one, right and left you can keep. Only if adult pads are used, you have to, for a child you are using. And we have something called as an attenuator. Next. So turn on, attach the pads, plug in, analyze, safe shock, resume CPR. These are the steps. Next. So this I showed already, you can move. Next. So there are two things. One is front back. That is an attenuator where you don't give shock beyond 50 joules in a child less than 8 years. More than 8 years, you are using the routine adult. Next. If you are using a defibrillator, you can open and you can have a pediatric paddles. Next. So if some adolescent are there or this one, they have air on chest, try to just attach the pads and pull it and you use a fresh shirt. Wipe any wetness is there. So, and if there are any pacemakers, see to that it is not, or ICD is there, see to that it's not placed on them. Next. So he is attaching the pads, but chest compressions are not interrupted. Next. So next. So while analyzing rhythm, don't touch. While giving shock, no one should touch. Next. So resume CPR after the shock. Next. So next is choking. What is choking? So some particle has got into. So what is universal sign of choking? Someone is holding like this. So someone is able to speak having distress and is coughing, allow him to cough. But if he's having universal sign of choking, next slide. Next. So are not able to speak. Next. So you can see here, he has kept his leg forward. What happens if I am giving a Heimlich's manual? If I am holding it both legs, suppose he falls unconscious, even he can fall forward or on me. So you have to keep your one foot forward and give the thrust. So you are holding and giving a thrust inward and upward between the umbilicus and the lower part of the chest, inward and upward. So suppose he falls unconscious, you want to start CPR. So your legs are there. You can use your front leg as a leverage and slowly make him lie down and start the CPR. That is the importance. So that step you should not forget. Next. So child, you have to kneel down. So in an infant, what you do is, I can sit down and hold. So you give you see to that this neck is extended. Hold your hands, 5 back slab, 2, 3, 4, 5. Then see to that this is also slightly extended, 2, 3, 4, 5. So, and at the end of 2 minutes, once you open the airway, see to that any object can be removed. No blind sweep. If it's clearly seen, try to remove it. Next. Next. So, opioid-related emergency, suppose you are suspecting Deferred, you can give naloxone. Next. So, I am not going much into that, but it causes breathing difficulty, altered consciousness, pooling of secretions, so respiratory distress. At that time, you have to give an antidote, naloxone, if they are suspecting opioid overdose or poisoning. Next. So what is important is at the end of 2 minutes, you can change the roles, and it's always better to have 2 persons taking care of ventilation. Next. So when it is a teamwork, it should be clear and road. Person giving compression should tell 1, 2, 3, 4 counting. The person giving breaths gives breath 1001, leaves 1002. Then other person, then he starts breath. It should be clear and road. Everyone should hear. And closed loop communication should be there. So anyone who is having some pain in hands and all should not be given a roles where like chest compression. It can be given a role such as to attach the pads, give shock. So that is important. Clear communication, clear roles, and closed loop communication so that everyone hears. So that oral communication during CPR should come. So that is what we lack when you are routinely working in the ward. We are just giving compressions without counting load. Next. So these are the checklist. So I have made a various stations are there with checklist. Someone wants to who have time to practice. We are ready to help out. Next. So there is something called as this is AI generated plus a person called as CPR coach. So he only directs the team, because if the team leader concentrates only on all other things, effectiveness of CPR comes down. So nothing is coming as CPR coach. He only tells the team leader, you do this other, or he tries to correct the others in between, so that he concentrates more only on the technical aspects. So most of this I have taken from BLS and Indian Society of Anesthesia. Most pictures I have taken from Indian Society of Anesthesia, because and also how to activate the code. Emergency. So at least you have to give 3 doses of adrenaline, and at least you should have done 10 minutes of CPR. In infants and all, they say at least 20 minutes. And after that, you have to have a discussion with the parents. That's what they say. At least 3 doses should be done. And every 3 minutes, 3 to 5 minutes, they say. The new guidelines, PALS or AHSA, every 3 minutes. So at least you should have given 3 doses of adrenaline, and there should be no signs of life. No, sir. As per no soda bicarb. No soda bicarb. Atropine only in bradycardia. Minimum 3. You can give more. That is left based upon the situation.
Give a mic, please.
Sir, if you CPR continued, in case inside the bleeding occurs, what you have to do? Or CPR, how long it will required? How many cycles? The exact 3 cycles or 5 cycles? Is there?
So, every 2 cycle is 2 minutes. You have to continue till at least you are given 10 minutes of CPR, 5 cycles of CPR and 3 doses of adrenaline, and there should not be any shockable rhythm in between. In between, you have a shockable rhythm, you might later end up having a shockable rhythm. So you have to look into the situations accordingly. So if when to terminate CPR, if you go to AHA guidelines, it tells there should not be shockable. Since you have started this one, there should be no signs of life and at least 10 minutes of CPR, and you are given 3 doses of adrenaline. All these criteria are met, this one. Otherwise, you have to take a call. And also discuss with the relatives when it is getting prolonged.
Any questions? I think we have one question from Sister Pariseva. She is the only international delegate in this conference. From Fiji, she has come to attend the conference. Yeah, please go ahead.
Okay, I have
Mike, please.
Okay. In regarding, you said for that the standard, is that the standard within 10 minutes?
No, no, that is minimum I told. You can prolong, see minimum. So after, you have to discuss with the parents and you have to look into all. If in between there was a shockable rhythm, you have to continue so that you might get a shockable rhythm again. So you have to continue it.
Okay. For that, because we will be running within first 2 minutes, for the non-shockable rhythm or the non-shockable CPR, when do we start the timing? 2 minutes.
And adrenaline.
Yeah.
Adrenaline can be given as soon as possible.
Yeah,
So-
yeah. Initially, we'll start with when
Because
it's
a person giving IV is separate, so she'll be giving.
okay.
So recent guidelines says IHR pulse should be given early as possible. You don't interrupt the compressions or ventilation.
Okay, no, sir, I understand that. But my question is, when is your time start?
Time. As soon as I start my compression first.
Is that a recent guideline for the
Means
university?
what is when your time starts.
When is the time start?
So once you have seen the patient and you start your compression, that is when the cycle starts.
Okay, sorry, sir. You will be allocating, as a team leader, will be allocating all who has to be there in a CPR. For the scriber is the one who's doing the writing and also is the one who's timing.
So
When is her time?
when you are timing, so if you go to a code blue sheet, it will tell time of arrest. So when did they call? So there will be a this one. So here based on infant, so unwitnessed collapse, I have to start immediately chest compression.
Okay.
That is there.
Sorry, sir. I understand. We will start with the CPR. But my question is for the scriber, when is she'll start timing for the CPR? When is her time start for the non-shockable CPR?
Timing of rhythm, when you are documenting, you have to document all the rhythms from the first, when the arrest occurred, possible time, when the code was activated, and when the time was there. Because important is, if you are delaying the compression, that should be recorded. So all the events should be recorded.
Sir, can I try? Can I try? Madam, can I explain? Okay, I will try. See, madam, is it sockable or unsockable rhythm? Depends on.
Yeah.
Suppose we attended a patient and in front of us there are changes in the ventilator on the monitor. That okay, now this is non-sockable rhythm and now chest compression should be started. So as soon as we start, okay, initial 4 to 5 cycle we can say that okay, now the blood start to reach to the brain. So at that time, after you can say 4 or 5 compression, you can say this is my start time. And the team leader patient is getting arrested, and we will not say that you will do that. You will not allocate a team what we do in that sort of simulation setting. Anyone who come, he will join, and automatically he will do a close loop communication that okay, I'm taking care of the drug part, I'm taking care of the defibrillator, okay, I will give orders, I am team leader. And these dynamics also keep changing. Team leader also changes, the compressor also changes. By the time someone expert come to here, take care of the airway. So that is also changed. So it's a dynamic situation.
There are two things in recording. It has first responder recording and the team comes recording. So you have to record both the first responder and the team.
Okay, I know that. Back to my learning. Sorry, I'm also dealing with the basic life support, do teaching. But to my learning, first for non-shockable rhythm, that's for CPR without giving a coach approach. Shockable rhythm, the first time, I know the scriber is the one who will be doing the timing all throughout. As we start, team leader is allocating, as we start with the CPR when coming in the ward, actually in ICU, I'm in ICU setting. The first thing they'll have to do, the scriber, when she start with the timing of CPR, as Until that time, we'll stop the CPR for shockable rhythm. Timing is start when we give the first dose of adrenaline. That's for a non-shockable rhythm.
No, what standard says is, I have been into NABH and all. So they look into entire events.
Yeah,
So when you give adrenaline, I have to record a time. So suppose arrest has occurred, you are starting recording a time at first dose of adrenaline, but the previous events are not recorded. That is also important, because as soon as you have this one, though adrenaline comes later in the list, but now they have started giving importance more to adrenaline if you go to the previous guidelines and the new guidelines. So you have to start when the arrest occurred, first responder, when they started CPR, and when ED was attached, and you start recording. Those first responder form is also important. And as a CPR team, when the whole team comes and you are recording it separately. But at the end, you have to analyze both the events. So when a team comes on this one, you are recording when it starts.
Yeah.
But as an event, you have to record the entire event. There is something called as first responder form, and the second is the team form.
I think what is the next plan now? We have hands-on training for them?
Yes, sir. If those who are free, they can have a hands-on training.
For questions, can I ask?
Yeah.
Yeah, you can ask during hands-on training, boss. Sir, the hands-on training is how we're planning the batches.
So we'll have 3 batches, sir.
We can have in the hall only, not outside the hall. We can plan in the hall only. Yeah, you can come close.
And anyone has they can come close.
Yeah, after this only. That's why we had initially planned in the skill lab, but we thought we'll have it here only. 10 to 15 minutes more. Afterwards, my vote of thanks will send. After that, national anthem.
So you can have any doubts.
Come forward, whoever else can do it and show. Come.
Sir? No.
Patient collapse and there is nothing to record.
No, that is gone, sir.
Initial thumb.
No, that is not there, sir.
It is sort of a shock.
It is not there, no, sir.
Not for children, not for adults.
Not also for adults also.
Yeah, people who interest can go there. It will be like, it will see on the screen also.
If you have doubts, you can come and ask.
Anybody interested, please come forward, please. Can do.
Sir, in my experience, I did on the CPR on the patient for 45 minutes. He was recovered. So that's why any protocol was there, any limitations.
That's what I said. There should not be signs of life, non-shockable, no this one, no movement for 10 minutes. All criteria should be met. Then only you are supposed to stop. If any one criteria is not meeting, you have to continue CPR. If all criteria are met, not shockable, no heart, no rhythm, and 3 doses of CPR is done, and no signs of life, then only all are met, you have to stop. Otherwise, no.
Thank you, sir.
So I have a situation where in a neonate, heart rate was 20, respiration came after 30 minutes. In fact, after 2 hours, child was breastfeeding, born to a malaria mother. So it's not that any sign of life, anything doubt is there, you have to continue.
Thank you.
Only all criteria are met, you are stopping.
Yeah, some more can join on this side also. We have another module here. City.
What do you want to?
No, actually, we wanted to.
From the boys side?
Okay.
Practice.
Huh?
Any scenario you'll give?
You want it? Okay, infant has collapsed, what you will do?
Whether the scene is safe or not.
Scene is safe. Okay. Check for response. Foot. Yeah. Check for response.
Can come this side.
Responding. Responding, breathing is there. Observe, reassess every 2.
Excuse me.
Check for response.
Tapping.
No response.
No response.
Shout for help. Sure. Anyone is there, please help me. Activate the code.
I am a single, sir. I'm activating the emergency.
Can give a mic to Shanti also. She is asking too many questions, so others will learn from her. Silence, please.
So first is okay.
Give one mic
This
to her
is single
also.
rescuer. This is a single rescuer. Child is unconscious.
Unconscious. The scene is safe, sir.
Hmm.
Scene is safe. Okay, I am checking for the response. Baby is responding, sir.
Not responding.
I'm activating. Okay, can anybody help? Can you help? Okay, sir, I'm checking for the pulse and respiration simultaneously. I'm checking the brachial pulse, upper arm, 1 in 1,000, 2 in 1,000, 3 in 1,000, 4 in 1,000, 5 in 1,000. I am checking pulse and respiration simultaneously. Any pulse respiration is there, sir?
So there is pulse is there, no respiration.
Respiration. Oh, okay. Then I have to give rescue breath.
Rescue.
This one?
EC clamp, yet till chin lift.
So I am giving
1001 squeeze.
head tilt chin lifter, neutral. Head
Somebody can hold the mic when she's talking to her.
So you have to do
okay.
a tilt chin lift.
Not a proper head tilt chin lift, sir. Okay, neutral position, because if I hyper extend, it will obstruct the airway.
Okay. But you have to.
I am holding. This is E. This is C. This is E. Okay. I'm giving one breath over 1 second.
1001, 1001, 1002 leave, 1003.
1001, 1002, 1003.
No. 1001, one breath, 1002, relax, 1003, one more breath.
Sir, one breath.
Or 1 second.
Please. Sir,
Breathe 1, 2, 3.
3 seconds. One breath.
Every 2 to 3 you can do. 2 to 3. Either you can do 20 to 30.
Yeah.
So you can use that. So you can 2 to 3 seconds.
Yes.
You can use that.
1001, 1002, 1003.
See, why I am important this, you are looking into 1:2 ratio. As a pediatrician, so I look into more ventilations in pediatrics than this one. So that's why they are kept 2 to 3 seconds. If I have to do.
Okay, I understood. 1001, 1002.
One breath includes giving breath and relaxing. So 2 seconds
sir,
is
1 second.
Someone from this side can practice on this. Mannequin also come.
1 second. Relax. Relax.
This is 1002.
1000. So it's one complete.
Okay.
So then, so this is one breath over 2 seconds.
Okay.
So if you are taking
1002. Chest is not expanding, sir.
Okay, so it's leaking here. So you have to correct your position.
No.
It's there is a leak here. Now you do. So if I, so there is a leak here.
Visible chest rise.
Visible chest rise. So. Okay, it won't raise. It's okay. Some issues.
Okay, some issues in the. Okay.
Bag and mask and chest compressions can be tried on the mannequins. So you can all please come and join.
So you can use this. You can have a chest raise. Okay. So expose it. So now a tilt chin lift. You can see a chest raise. See when you use
this mask is big, sir.
the round, give that round one.
Round mask.
No, it also you will get here. See, head tilt chin lift.
This mask.
See, you get it. Head tilt. If you don't, you are telling neutral position. It won't come. If you are in the, see, always compression, ventilation.
Oh, you said compression is first.
No.
But you said once it's there, no respiration.
So you extend it. Come to head end. Easy. Come to head end. You come here. It is easy.
Single rescuer side.
Single rescuer you have to use. That's all. Unless you are used to.
You have to give new
See
position.
what you are doing here. No, when you are using from this side, it should not go like this. So unless you do this, it won't come.
So many of us are there night and all.
So this mannequin is made to that tilt chin lift. Until that position is right, if you flex, it won't come. So you flex it. Now you do. So
Has to be continued for 2 minutes. Again, I have to check.
15:2. When 2 rescuers, 30. Rescue breaths every. Reassess after to 2 minutes.
So both pulses.
If a heart rate is less than 60, you have to start compression. If there is no this one, you have to first start chest compression, 30:2 if you are alone. 2 rescuers, 15:2. So when 2 rescuers are there, it's better to give this way. And make sure the most common mistake we do is we flex layer. So the nails dig into the sternum. So make sure that it doesn't dig. So someone was asking, hemorrhage is there. Only if you are pressing on the xiphoid process, there will be a fracture and hemorrhage. Or your
After 13 compression.
Squeeze, relax, squeeze, start breath. 1.
2, 3, 4, 5, 13.
You need not lift it.
12, 13, 14, 15. Wait.
15.
1.
Start.
1, 3, 4.
So someone can attach a pad now.
5, 9.
So she is doing this one. You can come here and attach a
Here.
AED. No, you don't stop chest compression. Continue. So you can attach a pad.
5, 6, 7, 8, 9, 10,
So
11.
I am
12,
doing here.
13,
I am
14,
attaching one pad here.
1.
Wait.
Okay. No. So at the end of this one, so then I'll you continue. You don't stop. Analyzing out with them. Remove. No, don't touch. Shock advice. Charge. So once you do any shock, continue CPR.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14,
15. Two breaths. Okay.
3.
Harsha will give another 5 minutes. After another 5 minutes, we are going to wind up. Lunch is ready.
12, 13, 14.
I have some concluding remarks to make.
Okay.
5 minutes के बाद.
Thank you, sir. Just like this. Like one, 2, 3, 4, 5, 6, 7, 8, 9.
Wait. I will come this side. You have to come this side. Chin. Head touch only. 1, 3, 4, 5, 6, 7, 8, 9, 3, 5, 6, 7, 8, 9, 10, 11,
Not so fast. You can speak 1001. Relax. 1003. So it should not be. One means it should not be fast.
Thank you, Dr. Harsha, Dr. Joy, Dr. Simran, Mr. Pirusab Donmani, Ms. Usha Shetty for an amazing presentation and live demonstration on basic life support skills.
1003, 1003.
Still want
Yeah.
Okay, so that's this. So shock advice. You can. No shock advice. Okay.
So this will be less in the here and there.
See, this it depends on
Now
component.
request the Dr. CS to kindly come on stage and give vote of
Can give,
thanks.
but it should not be touching. 1 year, 1 year you can place. It should be small. If it's an adult, front and back.
Okay.
Shall I announce?
This company has told front and back.
In front where?
Here.
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 Middle.
It should not affect your chest compression.
This is the.
No, here you can place. See, this is small. I can place like this. Not an issue. Only thing, this should not be touching.
Thank you, Dr. Harsha and team. Now I request Dr. C.S. Hiramat to kindly come on stage and hand over the mementos to the guests and faculty as a token of appreciation and gratitude. Doctor.
They are not there. जो भी है बुला डॉक्टर परिमला को बुला
She's not there.
she's sitting left side. I have seen her already.
May I request Dr. Parimala Simha to please come on stage and receive the memento.
Thank you so much.
Dr. Parimala, I would like to introduce. She is a senior professor, DM Cardiac Anesthesia at Jaydev Institute. Spends more than a week with us with loss of pay from her institute to serve the society. That's her determination. In fact, I call her as the divine mother in our OT. Come what any timings, whether it is 2 o'clock, 4 o'clock, babies from 500 grams to an adult of 125 kilos she is ready to do. I request Parimala to speak a few words. Madam, we are privileged to have you amongst us. Parimala is the wife of Dr. Prasanna Simha. He is here. Dr. Prasanna Simha was there, who was his student, and she was also his Dr. Tendulkar student.
Thank you so much. We all feel happy to work here because everybody has that dedication to do something good. And with blessings of Tendulkar sir and all the senior professors, we feel safe to work here. And also patients are also safe. Thank you so much.
Thank you, madam. Thank you. Thank you so much.
Dr. Prasanna Sinha.
Prasanna Simha is downstairs with all the team. Can somebody send a word, please, to call them? Yeah.
Dr. Harsha, please come on stage. Dr. Joy and Dr. Simran, their husband, wife. So we request them to come on stage and collect their memento. Tejaswini sister, our OT scrub nurse, please come on stage. Mr. Perusab Dodmani.
1 minute, I want to tell you something about Tejaswini. Our only complaint is I don't allow her to eat food. Starts from morning 4 o'clock till night 12 o'clock. She's ready, stands and sees that the child goes home. Such a dedicated sister she is. Thank you for being there.
Mr. Perusab Dodmani, the cath lab scrub nurse. Dr. Sai Sri Ranjani, our physiotherapist.
Peer Saab helps Dr. Eni in our cases where interventions without his involvement is difficult. As a surgeon, she also has a takes help of a nurse who takes care. And Sai Ranjani spent her life almost more than 20 years in United Kingdom. She left that and she has come down here. She is head of the physiotherapy department. Without her, I think the babies or adults going home without physiotherapy. Shortly, I'll be coming up with a conference only on physiotherapists also to see that we have the best taking care of our patients. Thanks. Thank you for being there.
Dr. Uma and all are not there.
Are they coming? Uma? Joy is there? I want, before somebody comes, I want few of the sisters to come and speak on stage about this conference, what you felt. Come fast. Other than Shanti, I want somebody else now. Come. One from this side, one from this side. Yes, please come.
First of all, thank you, sir, Hiramat sir, and whole team. Today and yesterday, we gain so much of knowledge regarding the pediatric cardiac subject. So actually, now in any way, the consider nursing team or the nursing staffs thinking very badly. But actually, see what we sir Prasanth sir says, the nurses are working in the patient side. It was very good, but actually, the comparatively, the documentations we totally we are not interested in documentation because we are taken place regarding the patient side, and the whole team and today, sorry, sorry sir, I am not. Stage fear will be there.
No problem, sir. This platform is created only to take out that fear. Somebody else, I want one more person. You are from Jaidev Institute of Cardiology, if I'm right. Somebody other outside Bangalore, who is there? Shanti is waiting to call. Huh? Viji, who is Viji? Fiji, huh? Fiji wants her to come. Shanti, you also come. Come first. Okay. You have a mic. Already she has a mic with her. Yeah, speak from there. No problems.
Okay, really, it is a fantastic and wonderful session, sir. And it was a feast for our brain, sir. Really, and we enjoyed every session, and they cleared all our doubts. Another thing, actually, there is no doubt. Only they cleared very well everything. They explained everything very well. So I think in the forthcoming session, I would like to send all my nursing officer to this conference, sir. And I appreciate everyone and all of you, sir, all the seniors who encouraged us to listen actively and participate. And you very patiently, you accepted our unnecessary talks in between the sessions, sir. Thank you all so much for your wonderful.
We have to accept most of the unnecessary things because otherwise we can't function. That's the problem.
Thank you so much, sir.
The last 1.5 day settings, I have got it recorded. It will be available on YouTube. Even today, you can click the 1.5 day program. Entire program is there live on YouTube, and the channel will remain open. You have to visit our Sathya Sai YouTube, the Madhusudan Sai YouTube. It will be available, and it will be further edited. And after 8th of this month, we will be editing and posting it further because 8th we have an international cricket match here. All the audiovisual team is very much held up. So after that, we will do. Not only that, anybody is interested to join nursing in our institutes, in our cardiac intensive care, they are most welcome. Tell all your friends, colleagues. You, apart from nursing care, you will know what is love and compassion standing here today. I don't think any of us cardiac surgeons of so many, whatever, blah, blah, so many degrees, sitting here in front of you, scratches their head day and night. How best I can make a nurse much better. Understood? So that's with that motto we started off. I would now request Dr. Joy and his wife Simran to come down. They are both pediatricians with our institute. Husband and wife, I'll give. Sir, nowadays people are complaining that there's no place to keep mementos in the house. So put together one. I'd like to thank our two supervisors, Shagufta and Leelavati. They are here. She's here. Where's Leelavati? She is also down for taking active part. And also the nursing superintendents who are there, DNS, Major Grace is here. And our Vasanta is here. And Mary is there. Grace, Ida is here. So all people are here with us. Without their help, it will be difficult. Sister Usha Shetty always keeps fighting with me in the ICU because it's not easy. She always fights, telling that if you are not available or for her thoughts, ideas, it's really pleasure to work with you to see that the end result of this fight is to see that the child goes home. That's only the end result is only that, nothing else. Madam has come. Dr. Karthik Ramesh is here. Yeah, please come. Dr. Karthik Ramesh, the AI master, he's been awarded as top 50 AI masters in the world. He's advisor to the Prime Minister also of our country. You should know whom we have bought. Thank you, sir, for coming with us. He has come all the way from Abu Dhabi for this conference to be here physically. He keeps coming here regularly. But any conference, I always see that how AI can be implemented in our medicine or nursing. We will see how the changes happen. As people suggested, to have exclusively an sort of an lab for AI training in nursing. Hopefully in the next visits, the lab will be ready. I'll put you on that lab for getting trained also.
I want to quickly thank Dr. C.S. Hireman because, they say it's not important. He's the chief cardiac surgeon for pediatrics, but it's not important to be a king or you have to be a kingmaker. So I think he's working with all of us at all levels of our responsibilities. And thank you, sir, because I really see him. He has visited UAE. In fact, Dr. Hiremat is coming in mid-Feb to UAE for CME there. He has met with the ruling family and they were very amazed with the work which Sri Madhusudan Sai Institute of Medical Science and Research is doing. Really amazing work. I think all of you need again, big round of applause for the selfless service which is going on here. Thank you, sir. Thank you very much.
I request Mr. Vivek to come up on stage, please. Vivek is an entrepreneur by himself. He sees that all the nurses are well placed across the globe. So during lunchtime, catch him. So see that whoever wants, all those things are there. He has a number of ideas. He builds nurses and as he told, with the 1-1-3 nursing, how AI can be utilized to increase. That's where he is looking at. I request Dr. Prasanna Sima, my teacher, mentor, who is here with us to please collect a memento. Please come. No, this 1 minute, please. One photo. I took this photo in fact, in the conference, I take this. He is his teacher, the first generation teacher of India in cardiac surgery. Second generation, I am into the third generation. It makes a huge impact. The amount of things we have learned from his teacher, and you see what kind of teaching you have seen in the last 1.5 days, how he's teaching us. I request Dr. Uma Nambiar to please come on stage, please. Thanks. I thank all the delegates for coming and participating actively. The more you participate, the more you learn. Okay. So, and I thank Tendulkar for making it very interesting. He'll be there for all the conferences. From my side, it is assured that he comes down always with us. In fact, he was telling, I am a cardiac surgeon, what I should do in nursing. That too, he is very keen in teaching only cardiac OT nursing, not ICU nursing. So I told you are important in the ICU also, please come down. And we could learn. I think with this, I would like to thank my audiovisual team, Siva Kiran and the entire team are there. Please stand up, please. A round of applause. Our IT team fellow Rahul is here. And the cameramans, Rahul, Murli and other team members who are there. This entire session has gone live across the world. And it is there available on YouTube. It's really helpful for us. If I missed anybody, not to thank, thanks for the catering department and our administrators who have really helped us. And thanks for the collaboration with All India Institute of Medical Science, New Delhi. QR code, they have already taken a photo and kindly fill the QR code so that we can improve subsequently in our upcoming conferences. I request all to rise up for the national anthem. Thank you. Delicious lunch is waiting downstairs. I missed thanking my joint secretary, Dr. Annie Arvind, the cardiologist. Thank you, Annie. Thank you so much for being there. Have a group photo. Hello, there only where you are standing, just squeeze in. We'll have a group photo. Just squeeze in. Murli, where are you? Come. So afterwards, a solo